I'm Dr. Rupali Gorgue, Organizing Secretary of ISA National Sponsored PG Assembly, joined with my friend Dr. Ankita Gosavi for MOC of this online meeting. On the behalf of ISA MIRAJ-SANGLI branch, I welcoming all our respected faculties, chairperson and our delegates. I, being in the academic field, always felt that PG students need special preparation before exams, and with this online lecture concept, they will be definitely benefited by all our prestigious national faculties. Special mention to Dr. Anjali Bhure ma'am, as it's her birthday today. A very happy birthday to ma'am, and we are very grateful that you took some time out for us in your special occasion. Thank you so much, ma'am.
Thank you, Rupali.
Now I request Dr. Vasudha Jadhav madam, our organizing chairman, to give welcome address. Over to you, ma'am.
Very good evening to all respected faculties and delegates. I am Dr. Vasudha Jadhav, and I warmly welcome you all as the President of ISA MIRAJ-SANGLI branch for today's online session. Happy Navratri to you all, and happy birthday, Dr. Anjali Bhure madam. First of all, I thank you all faculty speakers for accepting our invitation and sparing your valuable time for us. We planned this PG assembly at the end of our tenure, 2 years tenure, so that the PGs will get maximum benefit out of it. For the whole 2 years tenure, we conducted regular monthly meetings, clinical meetings. Then we did many online half-day CMEs, one-day CMEs. Then we also did a trauma conference, extracurricular activities, then financial awareness programs. Then even Ether Day celebrations we were awarded this year. And we did also BMD camp for the police force of Sangli district. The reason for telling is this, that I requested the national office bearers to recognize our efforts so that these youngsters who are in our association and executive will be encouraged. So with that hope, I divert myself for the today's session, as everyone is excited to learn from the experienced faculties. Once again, I thank you all and hand over to the first scientific session.
Yes, good afternoon, everyone. We will now begin with our first scientific session. Before that, it's a request to everyone except the speaker to please keep their speakers on mute. To all the delegates, please post your questions.
So I request our first chairperson, Dr. Anjali Bhure ma'am, who is a professor head of the NKP Salve Institute of Medical Sciences, Nagpur. She has almost more than 33 years of experience. Her area of interest is obstetric anesthesia, public awareness programs. She has so many national and international publications on her name. She was a vice president of ISA National, governing council member of ISA National, and she was honorary secretary of West Zone Assembly during 2009 to 2015. And she was the organizing chairman of Master Trade Chapter ISA ISACON 2021 Nagpur. She received so many awards. Second Best Branch Award at National Level, Chennai ISACON 2009. Then she was the most active member of ISA NCB during 2013. And she received the Sushila Sathe Memorial Award during 2017 and Signature Academic Award during 2021. Now I like to introduce our second chairperson, Dr. Anju Grewal ma'am. Dr. Anju Grewal ma'am, presently working as professor and head in the Delhi. She has almost more than 100 index journals and 14 chapters. Her area of interest are the obstetric anesthesia, CPR, airway, acute pain management, trauma anesthesia and acute care, regional anesthesia and scientific communications. She was the National President, Association of Obstetric Anesthesiologists. Then she was the President-elect, Raspecon, and former Editor-in-Chief, JOSCP. She was the former President of ISA Chapter Punjab. And she is the editorial board member and reviewer of many Indian anesthesia journals. Now I request our first chairperson, Dr. Anjali Bhure ma'am, to take over the session. Thank you, ma'am.
Thank you, Rupali. Am I audible and clear?
Yes, ma'am. Yes, yes.
A bright evening to all of you. It's an honor and my privilege to be part of this ISA National Sponsored PG Assembly 2024, which is organized by ISA Miraj and Sangli branch, Twin Cities, in association with Department of Anesthesiology, GMCH Miraj and BVTU Sangli. I congratulate the entire team of the organizers led by Dr. Vasudha Zadav, Madam, organizing chairman, and Dr. Rupali Gorjile, organizing secretary, for organizing this academic feast for our budding anesthesiologists. So I must thank the organizers for giving me this opportunity to chair this session along with Dr. Anju Grewal, one of my favorite anesthesiologists, and more so, she's a very good human being. And thank you so much once again. And I would like to invite our first batsman, Dr. Dheeraj Bhandari. So can I have a CV, please? And I take privilege in reading his CV. His qualifications are MD, DNB, PDCC, IDCCM, ADIC. I think all the possible degrees on earth. And his present designation and affiliation is he's Professor Anesthesiology, Consultant Intensivist and Nodal Officer, NEL Skill Simulation Lab, MGIMS Sevagram, Wardha, Maharashtra State. He has 14 publications. His area of interest are critical care, obstetric anesthesia, anesthesia for high-risk cases, simulation-based training, and quality improvement. So his major achievements are short-term WHO International Consultant for ICU, ED, critical care, and development of skill-based simulation labs at Timor-Leste. He is a gold medalist in MD Anesthesia and IDCCM, Young Talent Hunt ICCM 2015. The screen goes off. So, and Ayash Nairani is a Jaipur. He's a recipient of, he's one of the members of the National Task Force, member of ISA for COVID-19. I invite Dr. Dheeraj Bhandari, a wonderful speaker. Dheeraj, please come on this.
Thank you, ma'am. I'll share the screen. Thank you, ISA National, ISA Maharashtra, ISA MIRAJ-SANGLI branch, Vasudha Madam, Rupali Madam, for giving me this wonderful opportunity to be here at ISA National PG Assembly. And very thankful to Anjali Madam and Anju Grewal Madam. And it's an humble, I'm so humble to be talking in front of them. And I'll be talking about non-operating room anesthesia. So the first session will start from outside operation theater, and probably then we'll go back to OT. And I wish Anjali ma'am a very happy birthday also to start with. Thank you, ma'am. So there are no pictures used are for references, and there is no clear-cut conflict of interest. So what we are going to do is we'll be talking about definition and importance of NORA, and is NORA really different? And then how do I do it? Like the spectrum of anesthesia depth which is used for the same, and then PAC, intra-op or post-op, the way we conduct NORA, what are the guidelines we need to look into, what is the quality improvement process, which is very important for anesthesiologists nowadays to know it. And I'm not going to talk in detail about any drugs or any equipments or any particular monitoring device or about a specific scenarios like MRI, endoscopy or something. That is altogether a separate topic. But given in PG assembly, I'll be talking about NORA guidelines. Now, for any exam going point of view, the candidate, we must know there are certain must know things, and then there are desirable know things. Must know will definitely make you pass in your examination. And then if you start talking nicely in your vivas, if you start writing, expressing nicely in your examination, the desirable portion comes in, and that is basically reflecting your flow of thought or your thought process throughout the way you have conducted yourself in 3 years. So in must know, we need to talk about NORA definition and where it is needed, basic challenges for NORA, the way we will conduct, that is for PSC, intra-op and post-op for NORA cases, the ASA and ISA monitoring standards which are used, then options for NORA over spectrum from sedation to GA, and awareness about common complications. Now this is basically minimum no. And then if you talk more and more about this thing, as your viva will go and of your short note or anything will come about NORA, you should also be able to talk about complication rate in detail, about the challenges faced. You will should be able to talk, at least mention about the American Patient Safety Foundation 2020 Stolting guidelines, which were actually then adopted by the ASA and converted into NORA guidelines, and little bit about quality improvement and patient safety concerns. So now coming to the first part, that is definition and importance. you will see the nomenclature. So it is basically a non-operating room anesthesia, or NORA. Basically, it can be called as anesthesia in remote location or anesthesia outside operation theater. Whatever it may be called, the goal remains same. That is the patient safety, or the patient outcome becomes very important. Recently, we had World Patient Safety Day on 17 September, and we are fortunate that we are able to do this conference in such a near vicinity time. Now, why is it important for us as an anesthesiologist? This is one thing we should be taking ourselves very much of pride into, being an anesthesiologist. Anesthesiology over a period of time has been turning out as a model for patient safety in healthcare. And these are two wonderful reports. And Where they clear cut highlight the transitions which has happened in anesthesiology, from bringing down a mortality which was quite high under anesthesia to bringing it to negligible level by using all the possible ways and to use the systems of patient safety and quality improvement. We anesthesiologists have painted ourselves in leaders in patient safety, and the same stands very much true for NORA anesthesia. These are two wonderful reports. To Air is Human came somewhere around in 1999, and second still not same. And this, both these books, they highlight the way the anesthesiologists have been, I mean, they have been the pioneers, they are the safety champions in whole of the medical field in improving the quality improvement process and patient safety challenges. Now the question is, it's an anesthesia, isn't it, Nora? It's an anesthesia outside operation room. The procedure remains same. So we are not going to do something different, or this is there. And what is the big difference? The big difference is that we are going to perform, or we are going to give anesthesia in remote location. That is something away from our home turf. And if we are able to create more or less same standards, same outcomes at that particular location, then probably we should take ourselves pride in calling as a safe anesthesiologist. So that is why it's very important. Second is, why is the hype so much for NORA? I mean, like, why we are giving so much of importance to NORA nowadays? NORA is here to stay. Now, with increasing longevity of the patients, but with frailty, then they will be tolerating less invasive procedures, and there will be more and more options for NORA procedure. Physiologically, these procedures are more effective, less minimally invasive, and probably more effective. Technology has made it more and more possible. We couldn't imagine certain procedures probably a couple of decades ago, and now all of them are being done in a minimally invasive procedures outside the operation theatre. More and more branches are panning out, and there are novel innovations happening across. We don't only talk about endoscopy, but interventional cardiology, radiology, radiotherapy, and whatnot, isn't it? Cost effectiveness becomes a major concern now with all these changing financial landscapes, where everybody has been taking everybody is accountable for whatever things are being happening in the hospital or healthcare. This becomes very important. The NORA costs and everything are bringing down the cost of hospital, bringing down the cost of stay of the patient, and ultimately, therefore, we need to contribute in the same fashion to it. And the last is, there is significant enthusiasm amongst proceduralists. I mean, the people who are behind all this force, they are interested to try out new things, and we are here to support them and to give them a good condition from where they can have a good patient and safety outcome. Now, this is a wonderful 2017. I'll use the pointer. So you can see that the NORA cases, what I was saying was, it are going to increase from somewhere around 25% of cases in 2010. It has jumped up to around 35% of the cases. And by 2030, the projection is that almost 50% of anesthesia cases will be non-operating room anesthesiology cases. So it becomes very important for us to have looking into this thing. Again, the same thing. Currently, the most commonly procedures are in the GI scopy, and then followed by probably in the electroconvulsive therapy, cardioversion, and then interventional radiology and neurology. Now, coming to the second part, that okay, we have seen why it is important and it is going to stay here. How is it different in terms of what are the problems anticipated? Now, there are multiple ways to look into it. One of the easiest way to look into is, what are the problems associated with NORA? We can talk in terms of environment, HR, patient, and teamwork, a pretty straightforward approach. So if this is something, if you are writing a short note, this might work out well. So what we need to know is, there is a limited space to work and monitor. Lighting and noising issues are there. There are old equipments or no equipments and substandard monitoring in an NORA suite. We all agree with this. We are all doing this in our day-to-day practices. And drugs and resuscitation equipment and monitors may not always be available. Now, when I meant these are individual points which we can, of course, significantly ponder on. I'm not going to go into detail. Just giving you an example. For example, limited space to work. For example, if you are going in a cath lab, there's a small baby which is being being operated for say PDA or for example coarctation of aorta or something, the C-arm gantry is coming on the same side at the patient's head. We are not having any space to do airway maneuver or anything. So we are sharing common spaces, common places. Lighting and noising issue. Many endoscopists, they'll prefer the lighting to be dim, and at times we might not be able to visualize the monitors and everything. Noise issues, we not be able to hear what the patient has complaints, if there is an airway obstruction sound or something. Now coming to the HR part, you are going outside operation theater. You might not be having your comfortable postgraduates or your OT technician team or your OT nurses. They might be completely different people who are not trained from an anesthesia point of view, isn't it? We always say that अगर anesthesia वालों को जरूरत पड़ती है, तो anesthesia people are the best to help each other, isn't it? So anesthesiologist is working in an unfamiliar territory. There are multiple choices for anesthesia, and often we are not clear about the complications of each, and we might be juggling in during these things. Now, when we talk about NORA, we already talked that these patients are more or less higher ASA grade. They are not fit probably for your routine surgeries, and that is why they are opting for your minimal invasive surgery. Patient positioning again becomes a huge issue. For example, even your spinoplasty cases, in your ERCP cases, the patient might be in a prone position, accessing airway, and all these things might become difficult. And the most important part, and probably something which we even neglect in our operation theater, is there is no communication between the team. We don't know what the proceduralist is going to do, and the proceduralist probably doesn't know what we are going to do, and then the call for help is often not available, or if it is available, it is very late because they are suited quite away from operation theater. The most important thing is there is an unrealistic expectation of proceduralists. This is something which very important. See, in operation theater, you have one cases after another. We are churning out the cases. There is timeout. There are like 4, 5, 6 cases. Here, the cases are offering at a faster speed. The proceduralist, or the whoever the surgeon or operating intervention, he wants a calm patient, but he doesn't want him to give a complete general anesthesia, but he doesn't want the patient to move or anything. And this becomes a very unrealistic expectation. And this is something a good communication should always sort out. Now, if I have to look at it into more detail, suppose if I am being a team leader, if I'm coming to an anesthesia position of team leader. Hello. Okay, I'll carry on. So if I'm coming at a at a higher position, team leader, I need to look it from a patient safety and quality improvement point of view. I am an anesthesiologist, so I have been dealing with the various things. I have to deal with the organizational culture. I have to deal with the physical environment, which we talked about. We need to talk about the regulatory environment. We need to talk actually about the clinical procedure, and then the tools and technology. And this whole thing, this interaction will result into a clinical care process and will ultimately result into adverse event, complications, morbidity, and mortality. So this is basically a systems engineering initiative for patient safety. So if you are able to tell this in your Viva, actually it will be really impressive, and this will show your clear thought of action. So we can talk about environment factors, tools and technology, task, organization, and personnel. So basically these interactions is something which is very important for us. Okay. Now the second thing is changing demography. Now if you look at the changing demography, this is blue line represents operation theater, and the red curve represents operation NORA cases. You see the average age is also comparatively more as compared to OR cases. You look at the ASA 3 and 5 cases, there are more in the NORA as compared to operation theater cases, and the outpatient cases, which are something like the patient will come before, you might not have a good idea as to how his PAC is there, whether there was a multidisciplinary way to optimize his outcome. So this is also a problem. So these are all the problems which are associated with NORA or non-operating room anesthesia cases. Now, what are the complications observed? We have seen that, okay, these are the problems, but do they really, culminate, or they really actually bring out the complications? So let's see what the evidence has to say about it. Now, we all know, and if the postgraduates doesn't know, they should be very thorough. At least they should be aware about the concept of closed claims database and closed claim data analysis. The second is National Anesthesia Clinical Outcome Registers. This is basically followed in European and Western setup, but this is something which gives us a huge amount of data as to what has happened to the patients over a period of time, what are our mistakes, and how we can improve it upon them. This is most of the time a retrospective objective data, isn't it? Now, this is a wonderful article in 2017 where they have done the cases from 2008 to 2000, almost 15, and they have culminated and formed the results. Now, let's see what the results have to say. We are talking about now NORA claims, that is the medical legal claims versus the operation room claims. Now, let's look at the percentage wise. If you look at the age, sex, and procedure, the previous data which I was shown was a couple of years ago. Now, if you see more and more, there is hardly any demographic difference between the NORA claims and operation room claims. Now, what is the difference is, if you look at the ASA physical status, look at this percentage of 66. There will be more claims in ASA 3 to 5 patients in NORA cases. So we need to be more attentive. Now, if you look at the primary anesthetic technique, because MAC, that is monitored anesthesia care, is more commonly used, that is resulted into more NORA claims as compared to OR cases where you have more and more implications of GA. And look at the liability characteristics. This is something which is most important for all of us to look into. 66% and almost like 2/3 and 1/3 of these cases are deemed to be because of substandard care, and they can be definitely prevented by better monitoring. This is a significant area of improvement, and this is something which we should be remembering and trying to do and focus it on our day-to-day practice. Now, again, to elaborate the particular diagram which, or the particular graph which was there, if you look into this percentage of claims in location, the monitored anesthesia care becomes a huge concern for us, because not because it is a problematic procedure, because it is more commonly used in NORA cases. And secondly, I want to focus on, look at the inadequate oxygenation and ventilation. Because of the monitored anesthesia care, many times your airway is left unprotected, and you will see that the respiratory events are the most common adverse events in NORA. Almost around 1/3 to 1/2 of the cases or the claims are because of respiratory event. So if we know the problem, then we can do something about preventing it, isn't it? Now, this is something we talked about, an individual patient characteristic or anesthesia characteristic. Now, let's look whether the NORA are across whether it is whether it is the same across all the outside operation theater suites. Basically, if you look at this, in terms of gastrointestinal suite, cardiology, radiology, the toppers where you have maximum number of complications are basically in GI suite, in cardiology, and in radiology suites. And probably the one of the reasons is not because that these are more complicated, but because maximum number of cases also occurs in there. And most of the cases in these particular setups are done under monitored anesthesia care, where airway might not be always, like you might not be always securing the airway in terms of it. So if we are more aware about the problem, we might be able to control it in a much better way. Now let's look at the last part of complication, like what are the complications claim. Now, if you look at this percentage, this is the one thing I would like to highlight on. In NORA claims, the other claims are comparatively almost similar, isn't it? If you look at the permanent brain damage, aspiration, pneumonitis, airway, injury, pain, and all those things, they're almost same. But if you look at the death claims, the death claims are almost double as compared to OR claims. The reason being, if the airway is missed at the start, if there is a hypoxia or a hypoxia which is not detected, it might lead into a cardiac arrest, and that might cause a more of a problem. So this is again one thing which we all need to be very clear. So if you can, the same thing predicted in graph, in NORA cases, death or something which is more common and more commonly claimed for medical legal compensation. Again, the same thing, respiratory events, you'll have more problems with respiratory events like inadequate oxygenation and ventilation. The remaining complications are pretty much the same when we compare NORA and operation theater, that is operation theater and outside operation theater. So this is something which we need to be very focused on whenever we are giving our anesthesia or monitored anesthesia care to NORA patients. Now, one thing I want to talk about is, we always say, okay, I mean, like, if I am not given a muscle relaxation or a paralysis, why my airway is getting compromised? This might be a common question, especially for postgraduates. There are some wonderful articles. I'm not going to go into details of this thing, but this is a nice article where they did a pharyngeal video radiography and simultaneously manometry to see whether there was an airway collapse or not, and this was done in volunteers basically. So what you see is that as you increase the doses of sedating medications that are even subhypnotic, this can result in significant pharyngeal dysfunction, which is good enough to cause a airway compromise, especially in the difficult airways. For example, an obese patient or someone who has a high BMI. So this is something it should be always at the back of our mind whenever we are giving sedation to any patient. This is another a very nice article from anesthesiology, and what they say is ultimately when the patient moves from state of consciousness to state of unconsciousness, the genioglossus nerve shows a significant decrease in the electromyographic activity, and basically this is what we call as the tongue obstruction and potentially causing the airway obstruction. And this is all we all will agree that the state of consciousness and state of unconsciousness is a very thin line. I cannot say with a particular guarantee that propofol 1 milligram will not cause a state of unconsciousness in a patient, or whether a propofol of 2 milligram will cause unconsciousness in all patients. I mean, isn't it? It's a patient specific characteristic. But what we need to understand is as our doses are increasing, there is more and more propensity for airway obstruction, which we are all aware about, which is proved scientifically. And if your airway is insecure or it's not completely secure, so we need to be very clear about to prevent it. We'll see what we can do to monitor this particular thing. Now, oversedation leading to respiratory depression was just to be responsible for 20 NORA claim, with 2/3 of them occurring in the GI suite. Propofol was the most commonly implicated drug, and review were just that 68% of these oversedation claims can be preventable. That is, 2/3 of these cases can be prevented by better monitoring. And if not prevented, at least they can be detected early and then they can be treated in a proper fashion, isn't it? Now, the same thing what we were talking about, preventable by better monitoring, is something a huge percentage, isn't it? Almost 2/3 cases can be prevented by better monitoring. So now we have seen the definition of NORA. We've seen that how it is the different as compared to other thing, and then we talked about actual complications, and we compared the operation room complications and the non-operation room anesthesia complications, and we accept that there are certain differences. If not taken into consideration, especially airway problem, it will cause a significant problem. Now, coming towards the last section of our presentation, then how do I do a NORA anesthesia, I mean non-operating room anesthesia? We all understand this is a very basic diagram. All of us teach this in our first year, that basically anesthesiologist is a common factor between the triangle of patient, environment, and procedure. So when we talk about continuity of monitoring, we need to be doing it for pre-operative, intraoperative, and post-operative. And these 3 P's are something which should be like a mantra for any anesthesiologist, isn't it? We should be able to predict or anticipate the complication. We should be planning that if those complications happen, how do I do that? And once the plan is there, we need to keep ourselves prepared for in terms of equipment, in terms of personnel, in terms of drugs, as to how those do. And there are wonderful guidelines to help us predict, plan, and prepare for this continuity of monitoring. And this is not only for NORA, this is practically for all your critical environment. This is for emergency department, this is for your ICU scenarios, this is for your operation room, and this is also true for NORA cases. Now, these are the advisory, practice advisory. For NORA, I mean for pre-anesthesia checkup, we have a wonderful Indian Society guidelines also, and as to how to do a proper pre-operative thorough checkup and investigation. I am not going to go into this detail because this is beyond the scope. This is again a wonderful diagram. This is from basically anesthesiology. If you guys are interested, you can always go back. This is very fascinating, isn't it? Around 1984, the Harvard school, that Boston school, they started basic sort of monitoring standards. This was easily adopted by ASA standards, and then over a period of time, what they started noticing was pulse oximetry was introduced, then basic monitoring was introduced, capnography was introduced in 1990s. And what happened over a period of time is this 14 number, if you can pay attention to, the anesthesia related mortality decreased from 1 in 3,000 to 1 in 3 lakh. This has not happened overnight, isn't it? It's a continuous quality improvement process. So if we are going to implement this in our operation rooms, in our NORA setup, we need to start the process today to probably see the results over a period of time. So that is the reason why I've highlighted this slide. Again, we are very much aware about the various guidelines, including the ISA guidelines for basic minimum monitoring standards. I'm not going to go into detail about this thing, but there are 2 essential standards. First standard is you should have a qualified anesthesia present present in the room whenever these anesthetics are being conducted. And second thing is, whenever any anesthesia has been given, there are 4 things which needs to be monitored: oxygenation, Ventilation. Remember, oxygenation and ventilation are separate, not the same. We often confuse them. The third parameter is circulation, and the fourth parameter is temperature. Just to brief about this thing, oxygen we talk about pulse oximeter, ventilation we talk about capnography, disconnection alarms, circulation we talk about ECG, heart rate and blood pressure, and of course there is a temperature monitoring. In the same sequence, you can talk about advanced monitoring like pitch, tone, pulse wave, then various interpretation, focus and lactates. But this basic minimum monitoring, that is pulse oximeter, that is capnograph, ECG, NIBP and temperature, with the qualified anesthesiologist in the room, is the most important basic monitoring. If you are not doing, you are medico-legally liable to be prosecuted for a bad outcome for a given patient. Now this is second annexure, that one we have standard monitoring decided. Second is list of minimum mandatory equipment in operation theater. Again, a wonderful guidelines by Indian Society of Anesthesiology. You are all aware about this thing. I'm not going to go into detail, but basically something related to A, B, C and D. Isn't it? Another mnemonic which we all know about, the same thing we are trying to talk in terms of mnemonic, that is SOAP me, suction, oxygen source, airway adjuncts, position, and some might also talk about pharmacy, then meds and monitor, and ETCO2 equipment. That this is the preparation for any anesthesia case. You should have your difficult airway resuscitation trolley with a defibrillator, cardiac drugs and everything. And in appropriate scenarios, you should always also have your difficult airway trolleys. Again, this is beyond the scope. I'm not going to go into the detail. I am going to focus on ETCO2. Rest of the things is something now over a period of time, you all will agree that ECG, NIBP, SpO2 has come into clinical monitoring in our day-to-day standards. There are hardly any places now which don't utilize this basic monitor. Now, the important thing is about ETCO2. There are definitely cost concerns, but that is how we keep on improving. And it has been shown that capnography is a gold standard for airway intubation. We all know that airway management gives us a very short period of time. And if we are missing on the airway, especially in the critical patient, we might be losing the patient or there might be a permanent brain damage. So capnography is very important for all of us. This particular diagram I have highlighted particularly here is basically when we talk about capnography, we think that, oh, it is only for intubated patients. No, especially when we are doing a monitored anesthesia care patient, when we are away from the patient, when we are doing a NORA cases, probably awake ETCO2 monitoring becomes more and more important. And wherever feasible, we should always have a ETCO2 monitor. Again, it has been very clearly shown, if you are going to look into clinical observation of ventilation, it is very unreliable. Something which we do in MRI, they will put a video scope and will be observing a sitting in gantry room, and it might say. So what they say is your ultimate gold standard is basically your capnography, and if that is not there, then probably the other monitors is there. Just a quiz sort of thing. This is basically a Massimo respiratory acoustic monitoring. If you can see, there are sensors which have been kept on the patient's neck. This will try to listen to the tracheal sound, that is air in and air out going out. And this is something which have been used in NORA claim. Similarly, there are chest impedance device which will calculate your movement of chest, and they have also been shown that they can work almost in a good fashion if you don't have a ETCO2 monitoring standard. But there is no comparison to ETCO2 monitoring. Now, important thing is in operation theaters, we use timeout after every cases. We look at the patient. In a NORA, these procedures are short procedures and there are multiple patients. So they are happening at a fast pace. Do not forget to take a timeout between two patients. Okay. Probably a surgical safety checklist is something which can act as a good timeout, and probably we can have a good communication issues that these are the anticipated problem. This is what I'm going to do. The proceduralist might say, this is what I'm going to do. And okay, this is the plan in case of plan A, plan B for my complications. Again, now coming to actual, how do I do it? We can talk about angiolysis, we can talk about moderate sedation, we talk about deep sedation, and then we talk about general sedation. It's basically sort of a continued spectrum. The four parameters are responsiveness, airway, spontaneous function, and cardiovascular. You all know this thing, isn't it? But we can have NORA somewhere from minimal angiolysis to a spectrum of general anesthesia. Now, it is very important that we differentiate monitored anesthesia care from a moderate sedation analgesia. This is a very wonderful explanation. Moderate sedation is expected not to induce the depth of sedation, which will cause a problem with respiratory or cardio, and this can be done by almost the proceduralist. Anesthesia person need not be there. MAC will have varying levels of sedation, right from your minimal angiolysis to almost a GA, but this is always given by a specified anesthesia service. So all the components of PAC, intra-op and post-op comes into pictures, isn't it? Now the drugs and combination used are local, regional, sedation, GA, or the combination. And drugs, as we all know, we can use opioids, benzodiazepine. Propofol is the most commonly drug used. Ketamine, Dexmed has come up very nicely, or the combination, isn't it? So this again, not going to into detail, but more important to understand each drug's pros and cons, and then to use this in a smart way. Literature has highlighted that propofol complications are there, but the most important thing is when it is used in an optimum environment in the best fashion, it never leads to major morbidity and mortality. If you are having a complication, anticipate, engage proper monitoring, and then see whether that thing, whatever intervention you are doing, it is working out or not. Documentation becomes very important. I need not emphasize this again and again. So the last part is, how do I build a safe culture? So far we talked about an individual case as to NORA case, isn't it? Now if I want to build a good NORA safety point in my hospital, I am a team leader. If I'm going outside, if you are going to go into a private freelancing practice, and they are asking you that how do we build a safe culture, so these are some fantastic guidelines for the same thing. This is basically a ASA guideline, and there are 8 components, but this is essentially adopted from the 2022 Stolting Conference of the AAPSF, that is Anesthesia Patient Safety Foundation. For the time constraint, I'm not going to go into detail, but just to highlight few things. First is facility. When the facility is being built, the anesthesiologist should be involved right from its inception. I mean, from planning, construction, and then what you need to have is a reliable source of oxygen, electrical outlets, lighting, sufficient space, a source of continuous suction, and pre and post area as a minimum in the facility. The next thing is we talk about equipment, medication, and supply. Again, more important what I want to highlight is that anesthesiologists should be involved in the budget planning. Okay, otherwise ऐसा नहीं होना चाहिए that towards the end we are coming and whatever remaining budget is there, they are giving. Anesthesia machine, drugs, ambu bag, defibrillators, all of these things should be readily available in your NORA suits, isn't it? Then we talk about staff and teamwork. This is very important. The staff is something which is going to be outside your operation theater, and they all need to be supported with and trained by the anesthesiology trial team, and simulation protocols works very nicely in all these things. Then we should have a pre-procedural care and patient selection in the terms of PAC should be there. There are certain cases where we'll need more monitoring, anticipation should be there, and as we discussed, the timeout becomes very important. Intra-procedure care, pretty much the same way we want to give anesthesia, what we're talking about. We need to adhere to basic ASA or ISA standards. And the more important thing is, whenever you are doing a NORA, always identify a person who is going to come for your help, rather than कि मैं last moment में किसको call करूँ. There should be a designated way for call for assistance, designate person to respond, and then there should be a place for this patient in case if there are complications happening, where these patients will go. And then the post procedure, you should have this discharge criteria and recovery criteria documented very well. The last part, which is something which we daily miss in our thing, is quality improvement, that is quality review process and this thing. Pediatric, again, the same thing. Problem was with that the airway problem were more commonly identified. Radiology, again, the MRI problem is remote location, darkened room, and loud acoustic noise, heavy magnetic field, incompatible equipment. So this becomes a problem. The solutions are awareness that, okay, doesn't work. We have to classify the MR compatible instrument as safe, conditional, unsafe, and then of course techniques for sedation and monitoring way. CT scan, again, contrast allergy, strong radiation. Again, the problem is making this NORA suits more and more anesthesia friendly. Interventional cardiology, you will have more sick patient, radiation, there is shared space. The problem is again effective communication and planning and preparation. GI, aspiration risk, shared airway. There are bulky scopes which are going to compress the airway, prone position can be there. So the solution should be communication with the team and airway manage, anticipate, plan and prepare rather than creating an emergency. So the summarize the whole chapter, NORA is here to stay and expand, and we should be getting more and more share of it in our day-to-day because the increasing patient and procedure complexity. We all have seen that these data are there, that the most common problem is when the substandard care is there. and most claims involve GI procedure, cardiology, and radiology procedure. The patients are ASA 3 to 5 undergoing these procedures, and the most important complication we need to aware about inadequate oxygenation and ventilation. Properly, the 3 P's, that is preempt, plan, and prepare, and be thorough with your guidelines, be thorough with the quality improvement programs, isn't it? So this becomes very, very important. The most important thing I want to emphasize is, if we are having a good planning and establishing a good quality protocols, NORA is going to be more useful for the patient, for the hospital, and in long term for anesthesiologists in terms of monetary as well as medical legal concerns. So just remember this when you are going for your exam: must know and desirable know factors. And the important slide I found here was, if you are in an unfamiliar territory, you will automatically grasp onto what is already familiar. We are all anesthesiologists. We all know how to do anesthesia. Just need to be very confident about this thing and can deliver it. Thank you very much. Thank you. I just for giving me this opportunity.
Yeah. Thank you very much, Dheeraj. Now can we have some questions which are there in the chat box?
Ma'am, one question is, how much is the cost of MRI compatible monitor and workstation? I think to the best of my understand, GE, I think there is one monitor from Estiva basic series, but I think it is almost around 22 to 25 lakhs, and they do a complete complete suit. I think even Dragger has also got a recent one. I am not sure about the other monitors. Maybe Anju ma'am and Anjali ma'am can talk about this thing.
Anju, would you like to add that?
No, I think they are pretty expensive. He's very rightly pointed out. GE definitely has one. I'm not sure about the other companies. Definitely, what is more important is not only the anesthesia compatible workstation and monitor, but also laryngoscopes, simple things which we indeed take them inside ambu bag and all. They all need to be MRI compatible. So, as very rightly pointed out by Dr. Dheeraj, uh, planning is very, very important. Predicting and planning is what is the whole base of that entire thing. Yes.
Yeah, I'm sorry.
Sorry. Go ahead.
No, it's go ahead, Anju. Continue. Please continue.
No, I was just looking at other questions.
Okay. Many a times we hear that that jugaad which plays in our country. Many a times people wrap up the laryngoscopic blade and some sort of things which they do, and then they say kuch nahi hota. So can you narrate few incidences, Dheeraj, which can be detrimental? Even sometimes the oxygen cylinder is kept outside the MRI gantry, and from there the tubing goes inside and people
Yes,
give
ma'am.
oxygen. So what do you have to say for that?
As long as the jugaad works, ma'am, nobody questions. You will also agree. But the moment it goes wrong, you will, with today's medical legal litigation time, there will be absolutely no one to spare you. So I think if we are doing jugaad at a setup where at least in an institute level or somewhere, we should not go for jugaad and properly ask for a proper whatever is required for our side. They can buy a 2.53 crores MRI machine, I think, and if they want to do procedures, they can buy a 25 lakhs machine. Second thing is, if we look at the cost effectiveness, if I am a hospital administrator, I have to justify that cost. So what I can say is, if I am going to do more and more MRI procedures with GA and everything, I can show that I can recover the cost and everything. So that is one aspect of it. Secondly, what madam was saying was this thing, like for example, we understand in the MRI physics that the 5 gas line wherein nothing can work, and probably the zone of MRI 4, 3, 2, 1, where a pipeline is kept, even that infusion pump is kept outside, long PMO lines are delivered to the patient, camera is put at the back of the MRI gantry to see how the patients are working. So all these things work at the end of the day. There are very nice literature evidence in terms of neonatal MRI, where the technique of feeding and swaddling have been used. I mean, like, you feed the baby, you swaddle the baby, and the baby stays there for quite a good period of time. And they have done quite a good number of 2,500 cases with absolute no sedation. So probably we need to look into this and probably generate a good amount of evidence.
Because these are the people who are waiting for their passports. Once they clear their examination and they go in the field of private practice. I wouldn't say all, but then kuch nahi hota. So there are a lot of things. So a message has to go that all these things, as you said, the guidelines which are kept there are very important and should be followed stringently.
Completely.
Oxygen cylinder getting stuck and it goes like a missile. Sometimes, there are accidents of it is actually going towards the patient and harming the patient or the anesthesiologist or the OT person. I mean, the gantry.
True, ma'am.
Absolutely. And one of the most important things, as you said, is not only important to have safety precautions in institutions, but it's more important in peripheral setups because there would be nobody there to help. And so I love that very accurate thing that you said is that you must identify who would come to your help. Even in a peripheral setup, there have been multiple
ma'am.
instances in smaller towns, including Punjab, where people have gone out and just done and sedation hi to hai, and then ended up with aspiration, cardiac arrest. And the unfortunate thing is that we are not trained to even do a CPR, and how to take the patient out of that gantry during a cardiac arrest is something that needs to be having a mock drill and repeated session. So that is where this talk is very, very important here. I think we have a few more questions. Please, can you share your favorite combination in ASA2 patient? I don't know what exactly they want to,
Probably like people have started using propofol and ketamine or dexmed ketamine, and we also use the same combinations, and we are using it for a long period of time. I think everybody is using those combinations. As long as I was highlighting the same thing, as long as we understand the pros and cons of each drug, probably we will be able to utilize it the best in a given set of patient. I think that is there. The question again was, madam, supraglottic devices for radiological procedure. Absolutely. I mean, like everybody would agree that yes, there is a role for supraglottic devices for radiological procedure, even for interventional cardiology for that matter, and people are using supraglottic devices commonly. The point which Anju ma'am was highlighting is sedation hi hai aur kuch nahi hota hai. This is something which should be completely erased, and that is the reason why these NORA claims and OR claims were compared, where MAC had more problem and that had respiratory events were more problem. And if we are not trained to identify, we are talking this in a Western setup where people are comparatively more trained, there are more protocols because of more accountability. I should not say that we don't have it, but yes, we do lack in that. So probably it might have more complications in our setup. So it's very important that we create a good team dynamics and a good patient safety culture.
Thank you so much. I think you gave us a wonderful insight into how to plan and prepare for
Thank you.
NORA. Yeah, thank you so much. Maybe move to the second speaker.
Yeah, I'm so sorry because the connection I think went down and I'm again back. Thank you.
We'll
I'm
move
sorry.
on to our next talk. Predict, plan, prepare, follow. Thank you, sir, for such a concise talk. Now we move on to our next topic. Our next lecture is Role of AI in Anesthesia by Dr. Amrusha Raipure, madam. I request Dr. Anju Grewal, madam, to please introduce our speaker.
Thank you so much, Dr. Ankita, and thank you all the organizers of this ISA National Sponsored PG Assembly for giving me this opportunity to share with one of my most favorite anesthesiologists, Dr. Anjali. So it is a pleasure to introduce Dr. Amrusha Raipure. She is an associate professor in the Department of Anesthesiology, and she has various publications in national and international journals. Her areas of interest being pediatric anesthesia, regional anesthesia, airway. She has been a scientific chairperson of the Yuva Mahakon Maharashtra State Conference in 2023 and has been awarded the Certificate of Appreciation by Director AIMS Nagpur in 2023. Has also underwent observership at Westchester Medical Center, New York in 2022. I also see a lot of fitness up there. She's completed several half marathons, and it will be a pleasure to listen to you on the role of AI in anesthesia. Over to you, Dr. Amrusha.
I will just be sharing my screen. Can you see my screen now?
Yeah.
Okay.
Yes, ma'am.
Okay. Okay. So, good evening, everyone. At the outset, I would like to thank the organizing team of the ISA-sponsored, national sponsored PG Assembly and ISA MIRAJ-SANGLI. Thank you for giving me this opportunity. And thank you, Anjali Bhure ma'am and Anju Grewal ma'am, for introducing me. I bring greetings from the All India Institute of Medical Sciences, Nagpur. At the end of the talk today, I hope we are able to understand what is artificial intelligence, Where do we stand when it comes to AI in anesthesia management in the current scenario? What is the future, and what are the limitations that we see in the current scenario? Okay. Okay. So what is artificial intelligence? Artificial intelligence is basically anything that mimics human intelligence artificially. It can be through any means. It can be by recommending us to do something, by asking us to making some alterations, or actually doing some alterations, or solving problems. The subsets of AI include machine learning. This is the most widely applied arm of AI in medicine. It basically involves analyzing large volumes of data, like Dr. Dheeraj Bhandari was just discussing that, there are various ways in which we can collect huge volumes of data. AI helps, machine learning helps us in analyzing this data and predicting outcomes with the help of those data. It works on some simple maths on 4 pillars: statistics, linear algebra, probability, and calculus. Another subset that we are using increasingly now is deep learning and neural network, which simulates the complex decision-making power of the human brain. We are using this technology in the closed-loop pharmacological system that I'll be discussing ahead. Then the next thing that we mainly associate AI with is robotics, which involves performing dexterity and skill-based tasks. So when we talk about robots in anesthesia, there are pharmacological robots and mechanical robots. The pharmacological robots can be further divided into open loop and closed loop systems. The open loop systems are something that we are already using in our clinical setups now. These are the first generation pharmacological robots, like the TIVA TCI pumps, that target controlled infusions. In this, we basically set a target concentration that we want to achieve in the plasma. And with the help of the data that has been accumulated from various patients, on the basis of the patient's weight and the patient demographics, this this equipment is going to give us an estimated plasma and effect site concentration. So when I set a certain target concentration, the infusion pump will set a certain infusion rate for, say, propofol or remifentanil, and the drug will be given in a concentration at a rate so that that plasma concentration is achieved. But in this system, I do not actually know what is the actual measured plasma concentration. So for this, we have the closed loop system. In the closed loop system, we have a certain goal that is set for a variable that we want, for which we want to achieve a certain target. So the drug delivery is adjusted to minimize the gap between the set goal and the actual variable. In this, there are two types of robots. There is a CISO and a MIMO system. A CISO is a single input and single output. A single input, single output system in which I am targeting a single variable. For example, I want to target the hypnosis. So I will set a target range of BIS at, say, 40 to 60, and the closed loop system, the AI system, will take care that the propofol infusion is given at a rate so that the BIS is maintained at 40 to 60, or my inhalational agent is maintained at a rate so that that target BIS is maintained. Similarly, we can give a muscle relaxation infusion, or an infusion of an analgesic depending on the nerve stimulation guidance or on the basis of various analgesia scores that are available. The MIMO systems, on the other hand, will have, like we had single inputs here, the MIMO system will have multiple inputs in which at the same time we can address the hypnosis, the analgesia, and muscle relaxation simultaneously. So there was a study which had a hybrid sedation system that combined BIS to predict the depth of anesthesia along with the respiratory rate and oximetry, so that the patient was given an adequate depth of anesthesia and sedation, but at the same time, the patient did not experience any hypoventilation or respiratory depression. There have been multiple RCTs that have compared BIS-guided autonomous system with the manual systems that we commonly use. And it has been seen that the BIS-guided autonomous systems are far superior, consistently superior to the manually controlled propofol infusions. To just give you, how a typical platform of a MIMO system would look like. This is the interface of a MEX-LEPI MIMO closed loop system. So in this, you can see that, in this we have just used this you just have to enter the patient's weight, height, and the age, apart from the other parameters. And then you mention the drug concentrations that you have made. And then depending on the targets of the BIS or the TOF ratios or the TOF counts that you have mentioned, this system is going to perform in a closed loop manner so that we are able to achieve those targets with specific infusions of propofol and rocuronium or remifentanil going on. It is so fascinating that this thing is even possible. Similarly, we have closed loop systems for control of hemodynamics as well. So imagine you have a arterial transducer. In this system, you can see that this is a transducer, typically a flow track transducer, that is going to tell you the arterial pressure, the MAP, as well as the stroke volume variability. So this will tell you how the blood pressure is behaving. This is the monitor that will tell you the blood pressure. And then here is a noradrenaline infusion. So this monitor gets an input from the transducer telling that there is some hypotension, and it will give an input to this small thing that you see here is an infusion pump. So this will give an input to that infusion pump if there is any hypotension, and then this infusion of noradrenaline will go to the patient. If suppose I've set a target of MAP of 60, so if the blood MAP goes down to 50, so the NORAD, with this system, I don't have to do anything, and the noradrenaline infusion will start to achieve that target MAP of 60. So similarly, we can do that to have a target, goal-directed fluid therapy also with the help of the guidance of stroke volume variability or the PPV. So an ultimate MIMO system, a multiple input, multiple output system, where we could have something where there is a closed loop anesthesia as well as fluid management. So there is this, this highly complex system in which, there's closed loop for the fluid management and for the management of anesthesia. So there's the anesthesia workstation here where we can see there are inputs coming in regarding the BIS monitoring. And then this system can tell if the the targets that we are set are achieved or not, and it will accordingly change the rate at which the propofol infusion is going. So this system had, in this system, about more than 4,500 minutes of anesthesia was studied, and there were more than 3,000 propofol and more than 2,700 remifentanil target concentration modifications that were made. And through this entire procedure, in none of the time did the system had to be overridden by the supervising anesthesiologist. So, this obviously is in a very research stage right now, but it seems very fascinating where it can go. Moving to the mechanical robots, what can you think about? What do you want your mechanical robots to do? You want your robots to be able to do intubations. So yes, there are already systems that are, in the research stage to do an intubation. Now look at this, so this is an arm, this is the joystick, which can be operated by an operator, and this video laryngoscope can be operated, and with the help of that joystick, an intubation can be performed. In the simulators, it has been shown to have improved procedural precision. In that case, it will have better quality patient care. And the biggest advantage will be that there can be remote guidance possible by experienced personnel. So talking about intubation, they can be similar to the surgeons working on on the consoles of their robots. We can also do that, with the bronchoscope AI copilot robots, or a completely autonomous intubation robo system, or this Pyro Advanced Imaging Module. To make you understand how this Pyro Advanced Imaging Module works, let me take you through another video. So now this is a video laryngoscope, and at the tip of it, there is a bronchoscope. So now this is this view is the view that we are seeing from the outside. This is the view at the tip of the video laryngoscope, and this is the view at the tip of the bronchoscope. Now here, just look on the third vision. Here you will see a marker. So this bronchoscope is going to use that marker, and it will guide itself till that marker reaches the trachea, and it will stop there. And once it reaches there, we just have to slide our endotracheal tube over the bronchoscope into the trachea. Now, let me just play this video. See. So you just press a button, The bronchoscope is following that target. There, goes through the glottis into the trachea. And there, once it is into the trachea, it just stops there. And then you just have to slide your endotracheal tube and the tube is in place. It can be that simple. So this is something very new. I found this video somewhere on the web. Okay. So the next thing, you have got assistance with intubation. Now you want assistance with regional anesthesia. So some of the assistance of AI with regional anesthesia is already in clinical use, and there are already ultrasound machines that are allowing us to use AI during our actual practice. So how does that work? So, it helps us to identify the muscles, the bones, the nerves, the pleura, the lung tissues by giving them various colors. So, here also you can see that the muscle is given a certain color, the nerve has a certain color, the blood vessel has been given a certain color. So this augmented reality will help us to prevent complications and to actually be able to identify the nerve and to identify the location where we actually give the drug. If we want to advance this even further, there is a Magellan system which is USG guided nerve block assistance. This involves an automated pattern recognition algorithm to identify various tissues. It basically has something like a needle GPS technique with the help of electromagnetic or optical needle tracking systems. There's something called as a hydrophone system that uses a fiber optic stillet, which is placed inside the needle, and there will be spectral tissue sensing at needle tip, a lot of technical jargon, which will basically help us in identifying various structures with the help of the needle and the ultrasound and all the AI that can possibly be put to use. So, we have seen AI for as pharmacological robots. We have seen them as mechanical robots. Now we want them to do our intellectual work also. So they can help us with the clinical decision support as well. They will be very important cognitive aids for us with all the information that we can give them, and all the decision making that they can help us with. They can obviously not yet be put to use as autonomous in execution. So in the pre-anesthetic evaluation, they can help us with the prediction of post-operative morbidity and mortality, with the prediction of complications. And there are various studies that have been done, and it has been seen that they are much better at predicting the morbidities and mortalities that we are able to do with the help of the knowledge that we have. This will help us in counseling the patients, optimizing our patients preoperatively, and having an robust plan of anesthesia management. Not just that, just with the help of analyzing the patient's face and neck. Just imagine it takes a picture of the patient's face and neck, and it can predict the CL view more than what we can analyze with the help of the MPC grading and all the distances and the neck circumferences that we measure. Then it can also be used for selection of appropriate antibiotics and dosing. It can help, so many times we face the problem of translation when we are interacting with patients of different languages. AI can be such an important tool in helping us with those, difficult situations. Intraoperatively, it helps us with monitoring the depth of anesthesia and analgesia that we are already doing. It helps us with pop-up warnings. We have already discussed its involvement in the basis of closed loop anesthesia delivery. In the anesthesia administration, we have already discussed its involvement in the open loop and the closed loop systems. It can also help in the control of mechanical ventilation and weaning. The alarms in our machines constantly keep going, and there is likelihood of alarm fatigue. The AI can simultaneously analyze most of these parameters that are showing, and it can prevent false alarms and thereby prevent alarm fatigue. It can help with the predictions intraoperatively also by predicting hypotension in the next 10 to 30 minutes. So prior to when the actual hypotension is going to happen. So these systems are also again already available in the market. We are using it, and it can tell you whether, the hypotension is going to be because of a decreased SVR or because of a decreased cardiac contractility or a volume deficiency. And you can plan the patient accordingly and manage the hypotension even before, it is likely to happen. It can even predict, these AI systems can help us to predict hypoxemia and blood loss Not just that, by just analyzing the ECG and the blood pressure, arterial blood pressure waveforms, it can help us in analyzing the coronary insufficiency. Imagine the amount of benefit and prevention of the morbidity and mortality that it can help us with if we are able to do this in the intraoperative period. It can, in the post-operative period, by assessing the various parameters, it can help us it can help us to predict the respiratory depression and thereby prevent it. Analyzing the EEGs can help us with the pain management. Wireless PCAs can be used for remotely managing the patient pain. Early weaning from mechanical ventilation, early ambulation and discharge can be made possible with the help of monitoring through tele or video conferences. So with not just that, it can also help us in managing our logistics better. So there is an ongoing RCT currently known as the block op. It is still happening. It will, if in this, there is basically a Bluetooth enabled patient trolley that will help us to identify when the patient is wheeled in and when the patient is wheeled out, and several other parameters which will help us in predicting the surgical time, the rate of surgical cancellations, the ICU admissions, and depending on the team of the anesthetists and the surgeons, the type of surgery and various patient factors, it can help us in predicting the duration of the surgery. And, if there are any such changes, we can immediately reschedule our procedures, and it can help us in saving so much of our precious OT time and saving so much of resources. So, with all this, does it feel like these robots can replace the human, the human role that we have, the physicians that we are? But, these robots can obviously not take away the human factors that come into play. And just to give you an idea, let me take you to the next video. So this is a video of the RoboCup 2023. So these are the most advanced robots trying to play football. And look at this, just so that they don't fall down, there are humans supporting them. Okay, so there, so there he falls, and there's someone who's there to help him, support him. So, this is a neonate, a 30-day neonate in which we were giving anesthesia in the NICU to perform a tracheostomy. And imagine the amount of dexterity, the amount of coordination that we all need to manage this procedure. And looking at how the RoboCup functioned, there is no way that, the AI or the robots are anyway close to coming where we are right now. So that there's a very, very long shot, if at all, AI or robots get there. So the limitations that we face right now with using AI in anesthesia are that we require very, very large volumes of data. The quality of data is a deterrent. Like, the quality of EHR, the electronic health data, the electronic health records that we have that are needed are only available probably in the most advanced countries, not in the country like ours. The manual introduction that we do in a country like India, it is difficult to get these kind of predictions that are needed for machine learning. Besides, where there are rare clinical scenarios, all that we know through AI will definitely go for a toss. When it comes to research versus reality, the machine learning articles that are present in technical journals versus that are coming up in medical journals, there is a huge discrepancy in them. Okay, there are multiple hurdles that come in play when it comes to translating all these technical knowledge into clinical practice. Most of all, we need to understand that all these AI-based knowledge is probabilistic and not deterministic. It only gives us an idea that there is a probability of certain things. And in medicine, when it comes of patient health, when it comes of morbidity and mortality, we cannot solely depend on probability. Besides the dexterity, like I just showed in the last video, the dexterity is not to that extent now that it can replace us. ethics is one very important factor that we will have to take into consideration when AI becomes mainstream. Patient safety will have to be taken, we'll have to take into consideration. The patient consent will have to involve mentioning that we will be using AI while managing them. The patient privacy when it comes to using their data, and the staff will have to be specifically trained on protecting this data. My friend Shankar had, he's doing a lot of work in ML in medicine. He had helped me bring this presentation together. There's this lovely course, an online course by Coursera, AI for Everyone by Andrew. This is curated by deeplearning.ai. If at all you guys would be ever interested to understand more about how we can put this to use in, in our practices, this is the first stepping stone that we would be getting into. Thank you.
Thank you, ma'am. I request the chairpersons to please moderate the questions. Hello.
Thank you, Dr. Amrusha. So I know that I believe you and I have the same question. You had an excellent presentation, but will anesthesiologists become obsolete in near future? I don't think so. Yeah, we still will be needed. Yeah, our decision-making skills will still be ours. So the question here is, what will be the medical legal aspect of case aspect in the case of a mishap, especially a machine error coming in? So that is something we really need to address, I believe.
That's right. That's right, ma'am. So that will be, that there is still, forget getting into medicine, that's still a huge debate, even in the world outside of medicine. So when this is being used commercially, one of my friends is working in AI in the commercial field, and McDonald's was using AI, and in their vegetarian patties, they ended up using some pork because it was all based on AI. So who will be sued here? Whether the people who are utilizing that AI or the people who have made that AI. So, we are still not very clear about in the field outside of medicine. So it's still a very long way for us to go and understand where we will stand when it comes to utilizing AI in medicine.
But I think the aspect of augmented reality and virtual reality is perhaps a lot still an application. And you're correct to say that we need to be still the guiding forces to see how it is being utilized in an appropriate manner.
Right, ma'am.
Thank you so much, Dr. Amrusha. Thank you.
Thank you, ma'am.
Thank
Dr.
you,
Anjali,
ma'am.
any questions? Dr. Anjali is there. Yeah.
Yeah. I think Amrusha is there. Go on.
Yes, ma'am, I'm here.
Okay, Amrusha, we were entirely into some different world and things were looking very goody. Yeah. I would just like to ask you about the cultural and ethical issues related to this. What would be the societal or ethical issues which can come up?
Right.
So how, because it can definitely be complementary to humans, but
Correct.
when it comes to replacing humans, what is your?
Like I said, replacing humans is a very, very long shot before we get there. And when we probably start actually using it in real clinical scenario, we will have to make it a part of our consents that we are going to use AI-based technology in patient care, and we will have to make our patients aware of that. Besides, when we are going to even use their data, and when this data is going to be used for research, that is also something that will have to be addressed when we are talking about ethics in medicine.
Yeah, because if you go to see that they have that ability to quickly and accurately sift through the massive data, which the humans can't.
Correct.
Yeah.
Correct.
But when you keep on using, suppose in future, if we keep on using this, will clinical reasoning of humans deteriorate? What is your personal view about it? Because we are going to keep, everything is going to be, the robot is going to manage everything. So now
Right.
once we are in touch with the patients, we have that human touch and we understand the clinical reasoning. What is your personal view about it?
Maybe a little bit, ma'am. Like, earlier when we did not have the mobile phones, we remembered everyone's phone numbers at the tip of our tongue. We could just dial anyone's number. Now we
Yeah.
don't remember any phone numbers. So, those simple things that were on the tip of our tongue, those simple predictors that we just knew, that will probably not be a part of our system.
Yeah.
Maybe.
Thank you so much. Thank you very much.
Thank you, ma'am. Thank you.
Shall we move on to the next talk, madam?
Yes.
Thank you, ma'am, for enlightening us to a very new concept in anesthesia. We now move on to our next lecture, Pregnancy with Heart Disease, posted for LACS, Anesthetic Considerations, by Dr. Hetal Shah. I request Dr. Anjali madam to please introduce our speaker.
Yeah. Good evening, all. I would like to introduce Dr. Hetal Kumar Shah. He is MD PDCC. His present designation and affiliation being clinical lead in anesthesia in SICU, senior consultant cardiac anesthesia and intensive care. He has 7 publications to his credit. His area of interest are capnography, cardiac patient for non-cardiac surgery, and echocardiography. His major achievements are Chairman's Award for Best Doctor in Group, Dr. Kopp's Award by ISA in 2021, degree of diabetes management in special situation from Royal College of Physicians, UK, and reviewer of 4 journals. I invite Dr. Hetal Kumar Shah for his deliberation.
Thanks and good evening. Thank you, ma'am, for a nice introduction. It's my honor that I have been introduced by Anjali Bhure, ma'am. Let me share.
Oh, thank you so much.
Yeah. Is it visible? The slides are visible?
Yes, yes.
Yeah.
You're audible and clear too.
Perfect. Thank you. At the outset, I would like to thank the local branch of Sangli for inviting me, for considering me a person who can do justice to this topic in this PGCon. They wanted me to become present, but unfortunately, I was not able to travel that much because of certain issues. So, thanks for adjusting me for this online lecture also. Uh, Today we will be discussing a brief about the pregnancy with heart disease anesthesia consideration. 1 minute. Yeah. So the incidence of cardiac disease encountered in pregnancy is roughly from 0.2 to 3%. And it is of great importance in terms of maternal and fetal morbidity and mortality, as it is responsible for about 10 to 15% of maternal deaths. So out of 100 patients, roughly about 3% females, the parturient females will have cardiac disease. And out of those 3, probably 1 or maybe 1 or 2 might have morbidity and mortality. And usually what we encountered is a heart valve disease. It's not about the coronary disease which is happening, but it is more of a heart valve disease which generally occurs. And the commonest cause in India is rheumatic heart disease. And out of them, mitral stenosis is the most common clinically important valve lesion which we encountered in pregnancy. And the most important thing is that about 25% of those parturient will have the first symptoms during pregnancy. So they probably may not be 1 out of 4 is not aware about that they will have a heart problem till they become pregnant. And they pose a very unique problem for an obstetrician and for obviously for an anesthesiologist. And their anesthesia management can be challenging and it is quite risky as well. Now, whenever you have any cardiac valve disease, there could be either pressure overload or there is a volume overload, either on LA or LV, right? So, depending on those hemodynamic parameters which you understand, your peri-operative management uh, rolls around there, and you have to probably do some amount of hemodynamic alterations depending on the pathophysiology. So we goes quickly disease-wise. Anesthesia consideration in mitral stenosis in pregnancy. And rheumatic mitral stenosis forms about 88% of the heart disease complicating pregnancy in tertiary care centers in India. These are India data. Rheumatic mitral stenosis complicating pregnancy is still a frequent cause of maternal death. So what we need to understand and why it is so risky, or why this is causing a lot of morbidity and mortality, is because of physiological changes in pregnancy, the pathological aspects of MS over pregnancy, and all this with multidisciplinary approach can reduce morbidity and mortality. And with the invent of the safer drugs in a modern era and better monitoring, we can reduce this morbidity and mortality. So let's understand what happens. Before going that, let's understand what are the hemodynamic changes which happens during pregnancy. So this is a beautiful chart. The x-axis shows the week of pregnancies, and the most important thing which you need to understand is that heart rate starts going up till the first 16 weeks of pregnancy, then it becomes relatively stable in the second trimester. But in third trimester, again, it starts picking up. So tachycardia is a frequent feature in the first and third trimester. The cardiac output starts escalating in the first trimester itself, and then it plateaus down. Plasma volume of the body of the female, the mother, is going up, and it is having the peak effect during 32 to 36 weeks of pregnancy. And from the beginning of the pregnancy, the systemic vascular resistance starts dipping. Now, why this is important, we'll come to know. So what happens is that the blood volume, which increases by 40 to 50% during pregnancy and labor and delivery, which because of autodiuresis decreases in postpartum period. Heart rate usually goes about by 10 to 15 beats per minute in a normal pregnancy, while during labor and delivery, depending on the analgesia and the sympathetic drive, it can go very, very high. The cardiac output increases by 30 to 50% in normal pregnancy, which goes about additional 50%. So from normal cardiac output, you probably will have about 45 to 60% of the higher cardiac output during labor and delivery. Blood pressure, as I told you, because the SVR goes down, there will be a slight dip in blood pressure. But during labor and delivery, because of the sympathetic drive, it goes up. Stroke volume also goes up. And as we discussed, stroke volume, systemic vascular resistance goes down. These all changes will revert in a postpartum period. Now, why we need to understand this? So this decrease in SVR during pregnancy leads to decrease in systolic and diastolic blood pressure, which causes reflex tachycardia and increase in the stroke volume to compensate the cardiac output. And this cardiac output needs to go up by 30 to 50%. Now, if you have any valvular heart disease problem, this increase in the plasma volume, this increase in the cardiac output will lead to the transvalvular gradient. Especially in mitral stenosis, because the blood volume goes up, there is an increase in the capillary hydrostatic pressure happens, and that can cause pulmonary edema to these patients. Because of the blood volume which goes up, and there is an atrial enlargement because of mitral stenosis, the more chance of arrhythmia which happens to these patients. And on top of that, the hypercoagulable state of pregnancy and stasis of blood into the left atrium with the atrial enlargement both can trigger a thromboembolic risk to these patients. So what can other factors which can lead to cardiac failure during pregnancy in MS is infection, anemia, obesity, hypertension, thyroidism, and multiple pregnancy. Now, how do you manage these patients? Now, these are the patients are very challenging mitral stenosis patients during pregnancy, because what are the physiological changes which we saw, which happens to a mother? When you are managing mitral stenosis patients, you have to actually do the totally reverse of it. So we have seen that there is a tachycardia which happens, the blood volume which goes up, systemic resistance which goes down, and cardiac output goes up. While hemodynamic goals in mitral stenosis is to reduce the heart rate so that the LA fills the LV diastole time goes up. When you reduce the heart rate, the LV diastole time goes up so that the LA gets more time to get empty into the LV. You need to reduce blood volume to avoid pulmonary vascular resistance and pulmonary edema and pulmonary hypertension. You probably will have to increase the SVR to maintain hemodynamics, and you obviously need an adequate preload and cardiac output. While all those changes are typically ulta in pregnancy. So then this becomes a very challengeable condition, managing mitral stenosis and pregnancy. So how do you manage these patients? You try to give a medical management in terms of diuretics so that you can work with the additional volume. You give them diuresis. You give them beta blockers to control their heart rate so that the heart rate remains less. Ventricular rate basically you need to control, because these patients can be in atrial fibrillation also. So you give beta blocker and control the ventricular rate so that the diastole time increases and the LA gets time to get empty into the LV. If the patients are on digoxin, probably you in atrial fibrillation, then digoxin can help. And anticoagulants might require if they are in AF, or if they have a on echo, you may find that these patients have a LA clot. Then probably these patients need anticoagulants to prevent thromboembolic risk also. Now, if the patient is having a severe degree of mitral stenosis, then probably you can think of balloon mitral valvotomy or a valvuloplasty or a valve replacement surgical options. You probably will have to think, or probably you might have to think about termination of pregnancy also if there is a critical mitral stenosis. Obstetric management wise, whether to go for vaginal or cesarean section, I think the call is more on obstetrician side and it rather than anesthesia side. So what are the anesthesia consideration for mitral stenosis? As I mentioned, LV preload should be high. The lower heart rate is preferred, and that's why you probably need to give you probably will have to be ready with the beta blockers, maybe esmolol or beta log injections. Try to maintain them as much as possible into the sinus rhythm, because atrial fibrillation can increase the risk of thromboembolism. Maintain contractility, because the lower contractility in terms of LV underfilling can lead to hypotension. You have to maintain SVR because there is a fixed cardiac output state. So maintaining the blood pressure is very, very important, and you have to reduce their pulmonary vascular resistance so that they can have a less chance of pulmonary edema. Obviously, aortocaval compression due to the gravid uterus can cause decrease in the venous return and can cause less in preload. So you have to obviously maintain adequate venous return by avoiding aortocaval compression, maybe by giving a lateral position or putting some pillow onto the flanks. Good analgesia is very, very important, because pain during process of labor, there will be a lot of tachycardia which can happen. So if you can give a good analgesia in terms of epidural analgesia, then you can control heart rate because of that. And you should avoid hypoxia, hypercarbia, and acidosis, because all these can lead to pulmonary hypertension. And eventually, with the autotransfusion after delivery of the baby and sudden volume overload, these patients can go into flash pulmonary edema. So if you can avoid hypoxia, hypercarbia, and acidosis, this can prevent complication. Vaginal delivery, as I mentioned, good labor analgesia is very, very important, because labor pain can induce tachycardia, and then it can cause increase in the left atrial pressure and acute pulmonary edema. So good labor analgesia, if you are thinking for going for vaginal delivery, is probably a very must. Suppose if you are going for some obstetric regions or cesarean section, what to give? So ideally, no technique is perfect, and it should be individualized according to the severity of the mitral stenosis and patient condition. And you can think of epidural, combined spinal epidural, or general anesthesia. Spinal anesthesia can cause rapid onset of sympathetic blockade with intense vasodilation, can cause sudden hypotension and severe tachycardia. So it's a big no to give only spinal anesthesia for cesarean section for mitral stenosis patient. Epidural anesthesia is preferred because you can have a more predictable control of hemodynamics. So it is good. Suppose if you want to achieve a faster, let's say in a scenario where there is a fetal distress or maybe the cord around the neck, something like that, and you probably will have to do a quick cesarean section for this patient, and you probably will not have a time for giving epidural and getting the effect of the epidural, then probably combined spinal epidural is a better choice, that you do the onset of give a less spinal, so the onset will start, and then probably you can take over the further by epidural. So combined spinal epidural can be a choice of technique in this kind of patients where there is a real emergency and probably you have to go for a fast cesarean section. These parturients might be prone to develop hypotension with combined spinal epidural, even with general anesthesia. Usually with the sympathetic blockade, causes venous pooling, and that can cause hypotension. And those patients are also on a diuretic therapy and beta blocker therapy. So they tend to develop hypotension. Appropriate hydration is important, and low dose of phenylephrine instead of ephedrine. So why? Because phenylephrine only causes high SVR, systemic vascular resistance only they will increase, while ephedrine can cause both tachycardia and systemic vascular resistance increase. So tachycardia is to be avoided in mitral stenosis patient. So low dose of phenylephrine if there is a hypotension is a preferred choice over ephedrine. Contraindication to regional anesthesia, I mean, active heavy bleeding, HELP syndrome, thrombocytopenia, systemic sepsis or local sepsis, or patient refusal. I think these are the standard contraindication for regional anesthesia. Advantage is this of general anesthesia. Let's say if patient is saying no for regional anesthesia and you want to give general anesthesia, it's a rapidly established. Will have a better hemodynamic stability. High FiO2 you can give, which can reduce pulmonary vascular resistance, and you can control your ventilation. So that will probably have a less effect on pulmonary vascular resistance. Even if this patient goes on a pulmonary edema, you have a better control on ventilation. FRC can be increased because that will be decreased because of the pregnancy changes. So better VQ mismatch. You can avoid VQ mismatch, and you can achieve a good VQ. So that oxygenation and carbon dioxide management is much better. In case of arrhythmia which happens, you can cardiovert these patients under general anesthesia, and obviously, as I mentioned, there will be effective management of pulmonary edema. What can be the complications? If there is failed intubation, if there is a obese lady, lot of edema, then there is a possibility of failed intubation. Then it will be a risk to both Jacha and Bacha, both will have at risk. There is a possibility of aspiration. As such, pregnancy is a state where there is a possibility of aspiration. There can be hypertensive crisis because of intubation and laryngoscopy, and that can cause intubation laryngoscopy can cause arrhythmia also. On top of that, if there is an additional factor of hypoxia and hypercarbia, then this patient can immediately go into pulmonary edema. Uterine atony can happen with inhalation agents. Neonatal depression can happen with the inhalation agents, and there is a delayed recovery and increased incidence of PONV, which can be kept in a mind if you are giving a general anesthesia. What about uterotonic agents? Uterotonic agents have certain hemodynamic effects and should be used with very caution, especially in patients with a stenotic lesion, especially mitral stenosis. Particularly 15-methyl prostaglandin F2A alpha that will lead to increase in pulmonary vascular resistance should be avoided. So pitocin, not pitocin, this is prostaglandin, should be avoided in this kind of patients because of they have a decrease in the PVR effect. So you need to avoid this. So outlines of management, preconceptual counseling is very important. Correct cardiac factors, prevent infection, use anticoagulant therapy if need would be, infective endocarditis prophylaxis. If need would be, give advanced invasive monitoring. Mode of delivery needs to be discussed. And if you are going for a normal delivery, then probably labor analgesia is must. Oxytoxics should be judiciously used. Autotransfusion of blood should be monitored, because at this time, once the baby is delivered and when there is autotransfusion happens, these patients can end up in pulmonary edema. And you definitely need a high dependency unit for monitoring these patients. So obstetrician, neonatologist, anesthesiologist, and cardiologist, all this can join together and can have definitely a better outcome in this kind of patients. A bit of I've been touching on a few other valvular lesions like aortic stenosis. Uh, Aortic stenosis, there are two factors associated with the development of aortic stenosis. Is usually a degeneration and calcification, but that happens very at a late age. But bicuspid valve, congenital bicuspid valve, can cause aortic stenosis in a early age where our pregnant females would be there. So what is the pathophysiology? So there is an obstruction of ejection of blood into the aorta, and that lead to the increase in the left ventricular pressure. This is not a situation where there is a volume overload. This is the situation where there is a lot of pressure overload, which happens to the left ventricular, and left ventricle needs to be pumped very vigorously and very forcefully to come over the obstruction of the aortic valve, right? So there will be definitely a lot of left ventricular hypertrophy which can happen to these patients. The normal aortic valve area is 2.5 to 3.5 centimeter square. When can we label this as a severe AS? If there is a transvalvular pressure gradient higher than 15 millimeter of mercury, or aortic valve area less than 0.8 centimeter square, these are classified as a severe AS. And because of the left ventricular hypertrophy, there will be coronary compression which happens. So these patients might have angina pectoris with AS. And these patients can have syncope because of because of the low output scenario. These patients can have a pre-syncope or syncope, angina as I described. Obviously, because LV is, if there is a diastolic dysfunction which adds to the LVH, and there is a MR which develops, then these patients can have a dyspnea. They can have acute onset of pulmonary edema because of volume overload, and they will have a narrow pulse pressure. So how do you diagnose? From ECG, you will have LVH. On chest X-ray, there is a post-stenotic ascending aortic dilatation, which you can see. And on echo, you can get the severity of AS, aortic valve area, and transvalvular pressure gradient also. How do you manage these patients during anesthesia? The principle of AS, that AS is a fixed cardiac output state, and this hypertrophied LV is sensitive to ischemia. If you know these two things, how to manage, then probably you can manage this. So because it's a fixed cardiac output state, you cannot increase the cardiac output. So if you give a lot of volume, definitely there is no possibility that there will be much output which can happen to this patient. So prevention of hypotension is very, very important. And whatever the drugs or whatever the method you use, you should see that there is no further fall in systemic vascular resistance, which can lead to a decrease in the cardiac output. These patients are known for sudden cardiac deaths also, and if they arrest or if they have a severe hypotension, they are very difficult to resuscitate also, right? So what are the cardiac grid for these patients, or what are the anesthesia consideration? You have to keep the optimum preload to this patient. Heart rate should be low. Any stenotic lesions, you try to keep the low heart rate and try to keep them into sinus rhythm. Maintain contractility. You increase or keep a little higher SVR in these patients to avoid hypotension, and PVR you can have normal. So avoid tachycardia into these patients, avoid hypotension, especially in aortic stenosis patient, and optimize intravascular fluid volume to maintain venous return and left ventricular filling. So again, aortocaval compression you need to avoid in these patients. If there is a hypotension, definitely norepinephrine or phenylephrine can be a choice. Avoid agents which can cause tachycardia. So again, ephedrine is not a choice. Rapid transfusion if there is a hypovolemia which you can think. If there is arrhythmia, early cardioversion, because as I told you, these patients are difficult to resuscitate, and vasopressors if there is a sign of myocardial ischemia, which can happen. General anesthesia has to be given to these patients There is no choice of neuraxial block, especially if the AS severity is high, just because we want to avoid hypotension. Obviously, anything can be used. Maintain. The important thing is, if there is a marked LV dysfunction along with aortic stenosis, you avoid volatile agents to this patient. If you have to go for cesarean section, spinal is big no, and it is sort of contraindicated in aortic stenosis patient, and GA with invasive, preferably invasive hemodynamic monitoring is a choice. If there is a vaginal delivery, obviously careful epidural analgesia, because to avoid hypotension. But yes, epidural analgesia has to be given, and probably if you can use probably a bit of opioids into this, considering avoiding the fetal respiratory issues of or opioid effects on the fetal this thing. So calculative dose selection with drugs which can cause less of hypotension. You can safely give epidural analgesia to this patient. And if there is a fall in pressure, probably a touch dose of phenylephrine or norepinephrine to maintain blood pressure. Mitral regurgitation. The basic change in mitral regurgitation is that because when the LV contracts, a lot of volume which goes into the LA and very less volume goes into the systemic circulation. So this is a scenario where there is a volume overload which happens to the left atrium. So left atrial volume overload happens, and then it can cause, with increase in the blood volume during pregnancy, can lead to early pulmonary congestion to this patient. So diuretics, vasodilator, so that there is a less SVR, so that the more blood will flow into the systemic circulation. If there is arrhythmia, digoxin and anticoagulants, antibiotic prophylaxis. Surgical options are very less in recurrent lesions. Anesthesia management is the primary goal is to maintain the forward systemic flow. So you reduce, you do a tachycardia so that the LV gets less time to get emptied. So you do a tachycardia, you do fall in systemic vascular resistance. So these patients can tolerate spinal and epidural very well, right? So these are the patients whom you can safely and give, sympathetic blockade by giving spinal epidural. So maintain preload. A bit of less preload is very, very important so that they don't go into the pulmonary edema. Maintain higher heart rates as compared to stenotic lesions. You need to keep a bit of tachycardia here. Try to keep them on a sinus rhythm. Maintain the contractility and preferably less systemic vascular resistance so that the more forward flow which can happen to these patients. Watch IV fluids, so you don't give excessive fluids. Preload reduction with vasodilator, NTG can be a good choice in these patients with diuretics. You can give volatile anesthetic agents to these patients if you want to give general anesthesia to this patient if their LV function is good. No specific recommendation for management of MR during labor. You can safely give spinal or epidural to these patients. But yes, if these patients are having a low cardiac output or ejection fraction is low, or if they are quite symptomatic, then probably GA should be considered in these patients, right? Aortic regurgitation, almost similar management as that of mitral regurgitation, right? So I think I am not going to that much of the detail into this. Again, almost the same kind of cardiac grid to these patients, and they can also tolerate very easily the combined spinal epidural to these patients, right? Overall consideration, avoid aortocaval compression. Epidural analgesia is very important to these patients. Tricuspid regurgitation, a bit of tricuspid regurgitation is usually happens because of the RV dilatation, because of pulmonary hypertension. Very rarely because of infective endocarditis or rheumatic fever. Yes, abstinence anomaly can be one of the cause for tricuspid regurgitation, but it is usually well tolerated if there is no pulmonary hypertension to these patients. And I think the management remains almost same as that of the mitral regurgitation. So In conclusion, anesthesia in a patient with a valvular heart disease is challenging. The aim of anesthesia is to keep the diseased heart within its optimal working conditions, and using different cardiac grids, you can actually manage these patients. So this is the cardiac grid for all the valvular disease. Stenotic lesions, again, I'm just briefing that stenotic lesions, you consider decreasing the heart rate, keep them in the sinus rhythm and maintain contractility, and don't allow the SVR to fall much. So vasodilation to be avoided. While in recurrent lesions, you keep tachycardia. Obviously, sinus rhythm has to be maintained in all the patients, maintain contractility, but you can have a fall in systemic vascularization. So recurrent lesions, you can give sympathetic blockade in terms of spinal epidural, while in stenotic lesions, if there is a higher grade of severity, think of giving general anesthesia. Thank you.
Thank you so much, Dr. Hetal, for an excellent presentation of all the heart, heart diseases that we often commonly see in our practice. Yeah. I don't see any questions up there, but would like also to emphasize the fact that, as you very rightly said, we need to understand the pathophysiology behind the heart disease that the mother is has there, and understand the fact that it is around 28 to 32 weeks. That is the point in time where they're going to usually become symptomatic because of the underlying physiological changes that are going to exacerbate underlying problem. It will be also good for postgraduates to learn about how to classify them, risk classifications, especially the modified WHO classification of heart diseases, so that they know the risk stratification and how to go about managing these cases. Thank you so much for a comprehensive talk. I hand the mic to Dr. Anjali.
Thank you,
Thank you,
Dr.
ma'am.
Dr. Hetal, it was a wonderful presentation. So many valvular diseases compiled in such a short period. Thank you very much for a very comprehensive presentation. And the students will definitely be benefited. I would just like to ask before closing that what dose you prefer for a low dose spinal? You said CAC. So I think students should know that.
Yeah, so CSE, I would recommend, see, especially in a stenotic lesion. See, in a recurrent lesions, you can safely give of your routine dosage. That's fine, because when you decrease SVR, these recurrent lesions does very nicely. But especially this is a problematic in case of high grade stenotic lesions. So let's say if you have a mitral stenosis with the moderate to severe category, or aortic stenosis with the moderate to severe category, then the hypotension won't be tolerated, because these are the fixed cardiac output state. So, and suppose if you have a obstetric condition, which is like cord around the neck or fetal distress, where you can't wait much for epidural to no place the epidural, but and give the drug and wait for the effect, then probably a very low dose of spinal just to start the surgery, and then you top them up with the epidural, so that no the spread will also happen, because obviously because the physiological changes of the pregnancy, the spinal space is very less. So when you give a low dose of spinal, which maybe about 0.75 to 1 ml of sensor can heavy, and then you top up them with the epidural, the spread will happen. And then probably you can allow them to start surgery, and at the same time, the epidural effect will start chipping in. So I think that should be the way forward, especially if you have an obstetric emergency. Obviously, general anesthesia is the choice, but yeah, suppose because of certain reasons, if you want to go for a CSE, then I think that should be the thing. I have not purposefully taken up the cardiac risk assessment here, because then it will become a too lengthy kind of a
we understand.
presentation.
I understand that. Yeah.
Yeah.
And another point just to add for the students is, as I said, for low dose, it will be good to add an opioid, especially fentanyl. I would not advocate addition of clonidine in these, because hypertension would be quite profound. So 20 to 25 mics of fentanyl along with 5 milligram of bupivacaine heavy that you talked about in low dose spinal is something that should do the work for us. Yeah.
Yeah, I would be differ here. So I would add fentanyl in epidural dosage. rather than a spinal doses. So I want the baby to come out safely, because otherwise this opioid induced changes in the bradycardia or maybe the hypoventilation might trouble these babies very badly. So
But
I
So,
mean, I
but the
would add to the
injection does not
epidemiology.
cause much of a placental transfer and hence can be given safely.
Okay.
Yeah.
Yeah.
We too also give the same dose and we prefer fentanyl being given. It's fine.
Yeah, fentanyl, dexmedetomidine both can be safely given. Clonidine, as madam said, clonidine needs to be avoided in this kind of patients. And especially stenotic patients will tolerate bradycardia nicely. So for mother, it is a very, very beneficial. Yeah.
Thank you so much.
That was a great learning experience, Dr. Hetal. Thank you so much.
Thanks a lot, ma'am. Thank you. Thank you.
Thank you, sir, for your wonderful insights and concise talk. With this, we here and end our first session. Special thanks to our chairpersons for their time and presence. Once again, a very happy birthday, Dr. Anjali Madam. We are obliged by your lovely gesture. Over
Thank
to
you
you,
so much.
Dr. Rupali, for our next session.
Now there is going to be universal celebration, I think, for this birthday.
At least you can give all
There
of us
should
a
be.
digital chocolate.
Yeah. All of you, please have.
Thank you,
We can
thank you.
ask her.
Yes, it's an excellent talk, Dr. Hetal sir. Now moving to, and thank you, Anjali Bhure ma'am and Anju Grewal ma'am for excellent interaction. Now,
Thank
without
you so
wasting much time, now we are moved to our next scientific session. For that, I would like to introduce our chairpersons, Dr. Ganesh Prabhu sir and Dr. Pradnya Bhalerao ma'am. Please share the slide. Good evening. Dr. Ganesh Prabhu sir, who is our currently working as a Vice President of ISA National. He is working as a Medical Superintendent HOD of Anesthesia at Velamal Medical College, Madurai. His area of interest are neuroanesthesia, anesthesia for laparoscopic surgeries, orthopedic surgeries, and ENT surgery. Now, our second chairperson for the scientific session is Dr. Pradnya Bhalerao madam, who is my mentor also. Dr. Pradnya Bhalerao madam is MD anesthesiologist, currently working as a professor and head of the department and deputy dean at Government Medical College Hospital, Baramati. She has almost 25 original articles and 14 case reports and 4 book publications. Her area of interest is critical care and anesthesia. She was immediate past president of IIC Pune City branch and currently working as a president of Study for Society of Pain. And there are so many awards in her crown for good work in COVID-19, for clinical work and surgical store management. She received Best Teacher Award at GMC Miraj and BGMC Pune for academics and patient care. She had done fellowship in emergency medicine and fellowship in medical education, and she is the IRC instructor. She received COPS Award Pediatric Anesthesia and Gokhale Award for difficult airway. A very warm welcome to both the chairperson, Prabhu sir and Pradnya Bhalerao ma'am. And over to you, Prabhu sir. I request Prabhu sir to introduce our next speaker, Dr. Divatia sir.
Am I audible?
Yes, sir.
Am I audible, sir?
Yes, sir. Yes, sir.
Good evening, all of you. First of all, I thank the organizing committee for inviting me to chair this session. So I am much privileged to introduce our speaker, Divatia sir, who is our president of National ISA. Sir, welcome you, sir. He was HOD of anesthesia at Tata Memorial Hospital, Mumbai, previously. Now he retired and he's taken another job. Sir was previously the editor of IJA and now he is a president of our ISA National. And now he is going to talk about the acid-base balance. Welcome you, sir. I invite you, sir. Over to you, sir. Divatia, sir.
Due to some unavoidable reason, sir is not able to come online. I request Prabhu sir to introduce Bajwa sir.
Good evening, Bajwa sir.
Good evening, sir.
Good evening. Good evening. How are you?
Fine, fine, just like you, sir.
I am very much privileged to introduce Bajwa sir to the audience. He is a dynamic IAC secretary. Now, previously he was editor-in-chief for our IJ journal. He is currently professor and HOD of GS Medical College, Patiala. He is a very good orator. I hope you all will enjoy his speech. Sir, over to you, sir.
Thank you, sir, for the kind words. And it's always nice to be sitting along with Dr. Ganesh Prabhu, sir, in the governing council also, getting so many good advices from Ganesh Prabhu, sir.
Thank you.
So, this topic actually is more important practically also, because invariably, when we are doing the post-graduation and on the night duties or even the evening duties, emergency duties, we get many patients of trauma. And the most important part when these patients come to the emergency is the airway management in such cases, especially with the traumatic brain injury. The entire prognosis and treatment pattern depends upon how you manage these patients in the emergency. So even my college also, greetings from my college, that is the Gyan Sagar Medical College and Hospital Patiala. And we also get a lot of such trauma patients, and where we have got very over enthusiastic residents who do this management of airway in such patients. I think if we see these type of incidents, that these scenarios, you come across you're traveling across the globe, you will see these type of scenes, especially in India. The cars broken down, the severe accident, and sometimes the jams are also there. And these type of scenes also you will be seeing. So, but during that particular accidents, what has happened to the patients? That is a very, very important part. And how these patients are transported from this one to this scenario to the hospital settings. That itself is a very, very important part of a treatment of such patients, especially with the head injuries. Because the transportation is one such limitation, how to transport, when to transport, where to transport. So many questions arises when such trauma and accident happen on the roads. So people involved in road transport accidents, they often need airway management. The reason being very simple, for airway protection, to treat hypoxemia, as well as a part of CPR or a trauma resuscitation. So these are the main indications why these accidents victim, they require this airway management. Now, if these victims, they have suffered traumatic injuries, they are liable to have a difficult airway management. That also because of spinal cord injuries, which I will be explaining, then facial-maxillary injuries, then chest injuries and traumatic brain injury. These are the four headings under which the airway management becomes extremely difficult. And I think all the PG students, when they come across such accident victims, they see these type of injuries and they work accordingly and have to treat accordingly. Now, if we talk about globally, there are approximately so many accidents, almost 6 million deaths per year from trauma. That is almost equivalent to wiping out 3 big cities of India. That much population is, becomes dead when they are facing these accidents. And the traumatic brain injury and spinal cord injury are the most common causes of mortality in trauma patients. This everybody knows. I read right from the first year of post-graduation. The data we get from the European countries, especially this Great Britain's and the 225 deaths per day, because their data is very much in line with the reporting. In India also, we get the data accumulation, but mainly from the police registers, from the hospital records. And if you accumulate, even though is 1.5 lakh. It's underreported, but still it's a quite alarming if you go by the number. So these patients, when they land up in emergency, so what are the challenges in airway management of such patients? Because in such patients, the risk of occurrence of peri-intubation, physiological adverse events, which can increase morbidity and mortality and can lead to poor outcomes. And these are factors are mainly hypoxia, hypotension, and post-intubation hypocapnia. And what is this post-intubation hypocapnia? Because people like me, when I'm doing a first year post-graduation, I will like to do intubation to save a life. We are enthusiastic in our post-graduation, and we become a little bit overzealous when we are ventilating such patients. So these occur especially during emergency intubation. Now, what are the indications for airway management in traumatic brain injury? Do every traumatic brain injury requires airway management? So let's see the indications. First is if there is an apnea due to severe brain injury, or there is impact brain apnea. I think the postgraduate students may not be well versed with this term, but I will explain that also. And there's a loss of consciousness with the resultant functional airway obstruction. So these are the main indications for airway management in traumatic brain injury. So coming to the first, the severe catastrophic brain injury, it is associated with early death, and it requires a full trauma resuscitation, including endotracheal intubation. So there is no doubt, if the brain injury is severe, you have to do the airway management to resuscitate the patient. So you have to go for the endotracheal intubation. Now, coming to this impact brain apnea. So what is that? Is a post-injury apnea, when you just suffered a accident and injury to brain. This impact brain apnea is defined by the results in primary respiratory arrest without significant brain parenchymal injury. Remember that. And even if you are using the simple airway opening maneuvers, they may be sufficient, but they require a brief ventilation support to prevent secondary hypoxia. So that means in the ensuing time, if you give a little support to these patients, they will come out of this impact brain apnea and they will have a better outcome. So prognosis is good if treated well and treated in time. Now, third is the head injury with the loss of consciousness. This is frequently we encounter such patients in emergency. These frequently receive the pre-hospital advanced airway management. Now, what about the pre-hospital advanced airway management? Means they must have gone to some nursing homes, they must have gone to some clinics, and if they're lucky, they may have seen some anesthesiologists there who must have protected their airway, must have secured the airway with intubation or something like that, with the or maybe supraglottic airway devices. So that is what I meant by the pre-hospital advanced airway management. So in one of the study, the 30 to 40% of these patients are found to have partial or complete airway obstruction on emergency room survival. Now, for such patients, what are the points to keep in mind for better outcomes with airway management in traumatic brain injury? So these are very important points to remember when you are encountering such patient in emergency. See, first of all, the most important is try to avoid emergency intubation, except in apnea situation. The patient may have an accident, the brain may be little stunned. I think that may be the reason for little unconsciousness in that patient. So we should not go for immediate airway management in such cases. Although we have got some indication in the Glasgow Coma Scale, the score of less than 8, you go for the intubation. But in these patients, when they arrive in the emergency, try to avoid emergency intubation. Take precautions to adequately pre-oxygenate and resuscitate the patient. Airway management for airway protection should proceed only after adequate measures have been taken to prevent intubation-related physiological disturbances. What are those? That means the inappropriate laryngoscopy, inappropriate positioning, overzealous ventilation, so many things are there. and maintain cervical spine stabilization, keeping in mind the possibility of cervical spine trauma. Now, the term, when we were the postgraduates, we used to listen to the term cervical spine traction. That is not to be used anymore. It's more of a inline traction rather than inline traction. Now we are using the cervical spine stabilization. Then you should avoid the secondary brain damage because of your overzealous or inappropriate treatment in securing the airway, and need to avoid mismatch between the oxygen demand and delivery to brain tissues in the early airway management. So that means you should not be wasting time. If you are not capable, tell the senior who may be standing beside you to secure the airway. And early treatment and correction of hypoxia and acidosis can improve neurological outcomes. So as soon as you secure the airway, go for the other measures. So that means the cerebral resuscitation is very important. And avoid increase in intracranial pressure, especially during laryngoscopy and intubation. So the technique for securing airway in the emergency ward in such patient is very, very important. Here comes the learning curve. As good as you become in the intubation or airway management in this patient, you are going to provide a very good prognosis to such patients. However, the cavities, the suboptimal pre-hospital airway management leads to poor patient outcomes, because these are the golden hours. And if you are not secured the airway properly, you're definitely going to harm the patients. Now, there is a considerable geographic variations exist in case of inpatient pathway from injury through to in-hospital management. I think most of the postgraduates who have come to MIRAJ-SANGLI, they must have come through roads. And now you can easily imagine at many places, you may be in the remote villages, you may not be able to see the transportation to that extent. Suppose an accident happening at night, how that patient is to be transported, how you're going to secure the airway, how are you going to do the primary resuscitation when you're dealing with patients. Who's the primary responder? That's so important. The people of the villages, the people of the going on the side by road, they will be trying to put that patient in some car if it's happening, or some other trolley or tractor or whatever the truck, to at least transport to the another higher center. But here comes the variations in the prognosis, how you transfer, how you manage the primary, how you give the primary aid rather, and how you manage the patient primarily. So there is a considerable geographic variation in our own country. Endotracheal intubation in traumatic brain injury, it can be either in a hospital or the pre-hospital, as we have discussed. And you can do with the drugs or without drugs, but it's always preferable if you're in a hospital settings, go with the drugs. Because traumatic intubation without drug means, if you are able to do the intubation, but there's some trauma, and that too without drug, that means the patient is very obtunded, hence associated with a higher mortality. That patient is unlikely to, have a good outcome. And it's done to allow therapeutic intervention. Sometimes the endotracheal intubation in traumatic brain injury is done to go for the surgical procedures and also to prevent the secondary injury. And reasons for not intubating on scene can be lack of intubation skills and equipment. You will not find the anesthesia equipment easily available in the peripheries or where the patients are coming from trauma. Majority of the trauma patients are on the roadside, on the highways, on the connecting links road. So I don't think so there is a very good provision, or how people may be knowing that such patients require a good airway management or good primary management. So that is one of the reasons for not intubating on the scene. The studies have also been, evidence to these type of things. Like a study including 3843 patients from 45 centers, and the majority of the patients' trachea was intubated on a pre-hospital phase. I'm talking about a Western world. In the Western world, I'm talking about where the pre-hospital intubation was done. These pre-hospital intubated cases had a lower GCS scores, were more severely injured, and had a higher rate of non-reactive pupils and had higher injury severity scores for other body regions. Now, when these patients were intubated, I know maybe, I don't know, maybe who intubated them, who was the primary. You can't get anesthesiologists available everywhere in the countryside, even in the Western countries. So paramedics or maybe some people who may have knowledge about the airway management, they may have done, and we don't know how they manage. So this study is an observational study. You can't take this study as a, the one of the epitome of the study where you can say that if the pre-hospital care is done, so patient will have a bad prognosis. But it also depends upon who is attending to this patient. That's very important. So pre-hospital intubation in traumatic brain injury is usually done in severe head injury in a difficult environment, and usually the anesthetist will be present on the scene with pre-hospital team if the team is there, not with the everyday scene, and done when airway compromise persists after basic airway management by the paramedics. And benefits are very controversial in pre-hospital intubation. And the RCTs, various research articles have failed to demonstrate the clear benefits in pre-hospital intubated patients. And presence of the blood secretions, gastric contents in upper airways can increase difficulty. Many times these patients are not, they are full stomach, and when the brain gets obtunded, they definitely have a regurgitation, so higher chances of aspiration, which is going to again compromise their prognosis. And the limited availability of equipment, a personnel competent in airway management. So, see, this is one thing where our entire society, in our entire medical fraternity, the anesthesiologists are such a human being, such a person who can be good in such management. If you talk about all the specialties, maybe medicine, surgery, pulmonary medicine, whosoever, some are getting the, this one training and skills and acquiring the skills during their post-graduation or later part also. But anesthesiologists are one person who are going to define the prognosis on the global scenario, because these are the persons who are best and well versed in airway management, and they have a very good, well, they can easily use these devices, the supraglottic airway devices, the bag and mask, endotracheal tubes, and even the cricothyrotomy or other invasive maneuvers, they can also secure the airway. Now, the failed attempts at airway management, if you're having a very many failures at the attempts at intubation, this happens in the hospital setting also. So you are liable to have an increased mortality in such patients. Now, this is a topic of interest, the role of supraglottic airway devices in the pre-hospital airway management in severe traumatic brain injury. And I think this concept arose from the world wars, when such patients during a war were injured with so many injuries of the maxillofacial injuries, the brain injuries. So the supraglottic airway devices, they came into play at that time also, some way or the other. At that time, they were, it was devised later on by the person who has just expired. But somehow this role of devices to secure the airway were present in the World War II. The supraglottic airway devices were not in vogue at that time. The Archie brain could not define the things at that time, but still, it has come from the military medics. So the role of supraglottic airway devices is easier, faster to insert. You can train the way we are training our anesthesiologists throughout the country in resuscitation measure, and all the thing calls is going on. So this is one where we can teach our paramedics, even some educated lay persons also, about how to use the supraglottic airway devices, especially the second generation, because these are easier, faster to insert. The second generation devices are much safer and easier to use, can be used as a guide for blind intubation later, and conflicting evidence regarding their performance in the out of hospital setting is there. But still, if nothing is available, these things are available. They can be used by the paramedic. You don't have to go and attempt intubation in such patients. You can still use the supraglottic airway devices. And the promising results of correct orotracheal tube positioning blindly through previously positioned supraglottic airway devices in the mannequins is a good, the conclusion from many such trials is there. So, despite providing a good degree of protection against aspiration and microaspiration, supraglottic airway devices remain inferior to tracheal intubation. So, because these patients have suffered a major injury, So tracheal intubation remains the gold standard, but still it's recommended that whatever you have got in the pre-hospital setting, if you think the patient is not going to make it to the higher center, if you have a supraglottic airway devices, just go with it. At least try to salvage the patient. The use of an endotracheal tube in contrast to a supraglottic airway device in the management of out-of-hospital cardiac arrest seems to improve the probability of return of spontaneous circulation and a better neurological outcome. See, so endotracheal intubation is always, this is my personal thinking over the years that nothing is going to replace endotracheal tube in trauma cases. And pharmacological, if you ask, in the peri-airway management traumatic brain injury, muscle relaxant to increase rate of successful intubation. I think this is the best, but it's advised that these should be used by the anesthesiologist or the person trained in handling these drugs. And in the hospital setting, I think go for the succinyl choline, although it has been replaced by, at many places in the higher institutes, by rocuronium with the advent of the Sugama Dex. But succinyl choline is still the best drug if you get in a periphery where you secure the airway with a relaxed patient, you can easily secure the airway. It is a very, very helpful drug. It's a life-saving drug, I will say, in such scenarios. And intravenous agents to provide neuroprotection and muscle relaxation. Our times we were used to, lucky to see the thiopentone, which is again wiped off from the anesthesia desk now. That used to be a very good neuroprotective agent. And analgesic sedative described in trauma literature like etomidate, midazolam, ketamine, and opioids. And I can still say that ketamine, you may go with it to secure an airway. It is not going an acute dose. Acute dose means a single dose is not going to harm the brain that much, but it is going to help you in securing the airway. So that is a more on the beneficial side. And hemodynamic stability to be considered as primary objective when choosing the drug. So it is recommended not to use the propofol when the patient is having the hypotension. You are going to cause more harm. You are going to decrease the cerebral perfusion pressure more, which is going to harm the brain. So it's recommended try to use the ketamine and etomidate if it's available with you. And the lidocaine and fentanyl as adjuncts to standard rapid sequence induction protocol to blunt ICP spikes during airway stimulation. So these can be used if the availability is there so that the ICP doesn't increase during laryngoscopy. Actually, the ICP, if you're doing the laryngoscopy in a very good way, in the first 15 seconds, if you're able to secure the airway, I think there's hardly any increase in intracranial pressure. But over attempts, multiple attempts, definitely going to harm the brain with the rise of ICP. So what are the goals during endotracheal intubation of a traumatic brain injury patient? These are to maintain oxygenation, then avoid hypotension, raise ICP, then decrease cerebral perfusion pressure, minimize movement of head and neck if cervical spine injury is suspected, make mask ventilation requires more attention to prevent neck movements, cervical collar, manual inline neck stabilization is important, and cervical collar, be careful how you tie the cervical collar. Sometimes if it's tight, it increases the ICP and worsening of ICP dynamics by interfering with cerebral venous drainage. That's the reason. So be careful when you are tying the cervical collar. So manual inline stabilization, it causes a poor laryngoscopic view. So you have to balance that stabilization where you get the optimal view of the glottis. And cricoid pressures, this is controversial many times, but results in a radiographic cervical spine movement within physiological limits, however, may prevent successful bag mask ventilation, LMA placement, or tracheal intubation. So it can be harmful also. So what is manual inline neck stabilization? Use of inline stabilization and no inline traction. That is to be remembered now. And a Miller laryngoscope blade, it causes less cervical spine movement, but somehow the literature is still at controversy here. And the use of levering tip McCoy blade if poor laryngoscopic view, this is good. McCoy blade can be very useful in such situations. And other like Bullard, Pentax, and air track gyroscopes. So video laryngoscopes have come now. I think wherever the availability is there, better to go for these instruments in the first instance rather than waiting for the second. If you are well versed with their use and techniques, because securing the airway, we are not fighting for our own ego or glory that we can do with a laryngoscope. If you are well versed with the advanced airway gadgets, go with them. They actually, if you're going with them, they significantly lower mortality and improve neurological outcomes observed with a drug-assisted rapid sequence induction as per data from 2 large retrospective studies and 1 RCT. So drugs are important part if you want to secure airway in a brain injuries. So etomidate and ketamine, the negative effects of ketamine on ICP not shown in any studies. In single dose I'm talking about. And the ketamine etomidate are considered safe drugs in pre-hospital settings and in hemodynamically unstable patients with traumatic brain injury for tracheal intubation. Remember this, if the patient is hemodynamically unstable, go for ketamine etomidate as a drugs to secure the airway. And propofol use widespread in the hospital in severe TBI, but associated with severe hypotension in pre-hospital trauma. So better to avoid propofol unless until no drug is available. So ketamine midazolam combination is the best for out-of-hospital management in hypotensive patient with traumatic brain injury. There are many studies on this trauma medication. So I think all are I have already discussed. And trauma network should ensure that anesthesia and tracheal intubation is available where required within 45 minutes of an emergency on scene or where expertise is not able in an emergency department. What does that mean? The trauma networks are coming into play now with the DM critical care. After DM critical care, now we have going a DM trauma and critical care. So trauma medicine is also coming up. The emergency medicine has come up. So these type of branches, they are definitely going to establish network across the different part of the country. It may take some time, but trauma networks are very well, established in the Western countries. I think we are also on the path, but it will take some time. And safe, basic, and advanced pre-hospital airway management minimizes secondary brain injury. And if the patient is delivered to the neurosurgical unit in a timely manner, and it has improved traumatic brain injury outcome. There was one study where says if the availability of anesthesiologist is there, you will always have a better outcome and a lower mortality. So evidence on pre-hospital airway management in traumatic brain injuries contrasting, although we have established so many good things during this talk. And mostly are the retrospective studies because you can't develop a prospective studies very difficult to develop prospective study in such patients. And the low quality articles and the non-uniform reporting of data in pre-hospital advanced airway management and insufficient evidence on success rate of endotracheal intubation with use of neuromuscular blockade and conflicting evidence and impact of pre-hospital intubation in severe head injury. So correlation of Glasgow outcome scale with pre-hospital airway management difficult to explore, very difficult to define. But whatever we have discussed, that is very important. And SALAD technique, last of all, it's very important. The suction-assisted laryngoscopy and airway decontamination, it's very important. You must be using the SALAD technique when you are securing the airway. It's the constant suctioning provided by a catheter in the upper airway continuously by removing vomiting or a blood. So there is always an assistant helps you in this type of thing. So SALAD technique you should employ. And SALAD technique reduces number of attempts at intubation, but research on SALAD technique in emergency department has still not been conclusive. So for all the PG students who are going to the first year, you are maybe the second or third year, you can always help them in devising many research articles, research study, thesis, like role of the supraglottic airway device is the primary airway rescue device, conduit for blind intubation, role of early airway management to decrease early onset VAP. You can take a screenshot of this presentation, this page. So these are the potential topics which you can discuss with your teachers. You can devise the research topics on these issues in thesis or in the research articles or the research studies, even by the senior and assistant professors. So these are the good topics in the time to come. They will definitely help in accumulation of good data. So take home message is that airway management of patient with road traffic accident and traumatic brain injury is challenging. Goal should be to achieve favorable neurological outcomes by avoiding secondary brain injury, and research on various aspects of this topic is needed to go further in establishing our definite treatment. Thank you.
Thank you. Thank you, Dr. Bajwa, for excellent lecture delivered. You illustrated the effects of traumatic brain injury very well. Actually, in the traumatic brain injury is very common after the modern road traffic accident in the modern world. So every anesthetic has to be trained in managing the traumatic brain injury. And in the traumatic brain injury, the three things are to be concentrated. One is hypoxia, that will be airway management. Securing the airway is a primary important, and treating the hypoxia, that is ventilating the patient. And third one is uh, stabilizing the cervical spine injury. If there is a cervical spine injury, you have to stabilize that. These are the three things. And apart from this, sometimes brain edema may occur. These may be treated by IPPV, diuretics, and steroids. So these are all of the major catastrophes that is occurring in the traumatic brain injury. So actually, your lecture is will be much benefited for the postgraduate students. Those who want to have a question, they can raise it in the chat box.
Yeah, they can write anytime in the chat box. I will be answering them. And actually, what you are saying, the cerebral edema, sir, actually, we are dealing with the first part of the brain injury till the airway management, because the first primary treatment is there. Cerebral edema, the cerebral resuscitation starts after we secure the airway. Then when we are going for either the surgical intervention or going for the critical care, then I think those measures I haven't discussed because we are dealing with the primary here. Definitely, when the cerebral edema is there, there's a lot of decongestants are there. There are a lot of other methodologies are there to decrease the cerebral edema, the effects of the cerebral edema on the brain. That is there.
Another very important part which sir has discussed actually, Bajwa sir, and he always is on the basics. So what you can do in a scenario where everything is not available. So use of ketamine. We keep harping on no ketamine in traumatic brain injury or neurosurgery cases. But a single dose of ketamine will cause no harm, and airway management is most important than anything else in this situation. So he has highlighted that very well. Thank you, Dr. Pachwa.
Thank you, ma'am. You are always just like a mentor to me also. And these are facts actually. But we should not follow anything blindly by the Western society.
It should not be protocol based all the time.
Yeah.
I think sir has explained the lecture so nicely, so that's why there is no question. But if it's there, we can discuss it later.
Dr. Rupali ma'am, are the PG students sitting in one hall where you are live telecasting this?
No, sir.
Only on the Zoom only.
Yeah, it's on Zoom only, sir.
So you must record this session. You can display to them. You can give the.
It's already recording is sir going on, and we are going to display.
What I want, pen drive should be given to the PG students. If I think when they.
Yes, sir. Definitely.
Lectures.
Okay. Thank you, sir.
Thank you.
Thank you, sir, for.
Thank you, sir.
Sir has very well you delivered the informative talk, and also ma'am Pranam said that sir has put the highlighted an insight about the use of ketamine in traumatic brain injury. That's really clear most of us confusion about the use of ketamine in traumatic brain injury and even neurosurgery also. Now I request Dr. Diwatiya sir, to our ISA National President, to start his lecture on arterial blood gas analysis. Over to you, Diwatiya sir.
Good evening.
Sir, Diwatiya sir, good evening.
Sir, Diwatiya sir, good evening.
Good evening, Dr. Baj.
Welcome.
Doctor,
welcome to the meeting.
Very much.
All the postgraduates are waiting to hear your interpretation of blood gas analysis.
So, thank you for inviting me here. I hope you can hear me. And,
yes, sir.
So I'm sorry I could not come here. As Dr. Ganesh Prabhu mentioned earlier, I've just recently got a new job, and I don't have the kind of leave I used to have when I was in Tata Memorial Hospital. So I cannot come to MIRAJ-SANGLI as much as I wanted to. Apologies to you, Dr. Rupali, and also to Dr. Ashok Deshpande, who was all set to book my flights and everything. But, I told him, please don't do that. And if Dr. Anjali Bhure is still around, many happy returns of the day to you too, madam.
Yeah,
So,
Dr. Anjali Bore, ma'am. Is she there?
I think she left, sir. Actually, she told
Celebrating the
me,
birthday.
yeah,
this-
celebrating her birthday.
okay, so we'll talk now about interpretation of the arterial blood gases. And, before we start talking about the measurement, I think it is very, if any of you have seen a blood gas report, it's got so many parameters. But we need to remember that only 3 electrodes are present in the blood gas machine. So these are the measured parameters. And they measure the pH, they measure the PO2 and the PCO2. So these are the measured parameters. And all the other parameters that you see, including the bicarbonate and saturation, uh, uh, are calculated based on nomograms and algorithms. Okay? Except in a co-oximeter, the arterial oxygen saturation is also measured. But otherwise, base excess and so on, they are all calculated parameters, and these are the measured parameters. Now, traditionally, I mean, we do the blood gas analysis for 2 reasons. One is for interpretation of the acid-base status of the blood, and the other is, for the interpretation of the oxygenation and ventilation status or pulmonary gas exchange. And what I'm going to do is, I'm going to focus initially at least on the interpretation of the acid-base status, because that is the most confusing and that is the most, difficult part. And if there is time, I may talk a little bit on blood gases of oxygenation and gas exchange, but otherwise I'll stick to the acid-base status of the blood. So there is when you look at a blood gas report, you must do a stepwise approach. Don't just try and make a diagnosis very much like reading an ECG. Don't just look at the ECG and try and impress somebody by giving a diagnosis. Go in a systematic fashion. And these are sort of 7 steps. It is also very important, for all anesthesiologists to know a little bit about blood gas analysis, especially the PGs, of course, for the exam, but even for practicing anesthetists, is because, when a blood gas report comes to the OT, no orthopedic surgeon or gynecologist is going to be able to make head nor tail out of the blood gas, right? So you are the one they are going to rely on to tell you what that report means for the patient and for the treatment and so on. So it's nice to know how you analyze a blood gas report. And this is the sort of steps that you go through. There are sort of 7 steps. And if we go over in systematic fashion, we'll have a very good answer. So let's go over all the steps one by one. Please remember, that while there are normal ranges, the pH, PO2, CO2, all those things have normal ranges. But when we are analyzing the report, we take only one sort of number as a normal value, and that is 7.40 for the pH, 40 for the PCO, and 24 for the bicarbonate. So these are the normal values which we take for when we decide to analyze our blood gas. Okay. So when we start with the pH, okay, well, is there an acidosis or is there an alkalosis? So if the pH is 7.4, that's normal. Anything less than that is acidosis, and anything more than that is alkalosis. In for all the PG students, some Khadus examiner will ask you, what is the difference between alkalosis and alkalemia, or acidosis and acidemia? And it's a nitpicking answer, something to make you feel a little bad, and but this acidemia is acid in the blood. Alkalosis is alkali in the blood. Anything emia is in the blood. And acidosis is the process which leads to acidemia, and alkalosis is the process which leads to alkalemia. But we use these terms interchangeably, and I think most of us are used to the terms acidosis and alkalosis. So we'll stick to that term, although the most correct technical term would be acidemia and alkalemia. Okay, so pH on this less than 7.4 is acidosis, more than 7.4 is alkalosis. So let's assume you've got this blood gas in front of you with a pH of 7.3, a CO2 of 60, and a bicarbonate of 30. So this tells you that this patient has acidosis, right? Because the pH is 7.3. Then you have to look at 2 components, the respiratory component and the metabolic component. We know that the pH is determined by the balance between the respiratory and the metabolic components. So the first look at the respiratory component. and the normal PCO2 is 40. Any PCO2 less than 40 is a respiratory alkalosis, right? Because CO2 is acidic. So if there's less CO2, then you get an alkalosis, and this is called as a respiratory alkalosis. If the PCO2 is more than 40, you call it as a respiratory acidosis, right? And then you look at the bicarbonate, which tells you about the metabolic component. And if the bicarbonate is less than, normal is 24, anything less than that is metabolic acidosis, and anything more than 24 is metabolic alkalosis. So now in this patient, we've got a pH which is acidotic. The CO2 is 60. So this patient has got a respiratory acidosis, and the bicarbonate is 30. So he's got a metabolic alkalosis. So this patient has a acidemia with a respiratory acidosis and a metabolic alkalosis. So the question is, of this, which is the primary disturbance, right? He's got a respiratory acidosis and a metabolic alkalosis. So which is the main or the primary disturbance? And the answer is that which is in the same direction as the pH is the primary problem. So, for example, if you had a pH which was alkalotic, at a metabolic acidosis. Dr. Ravikiran, you need to mute yourself. Yeah. So if you had an alkalosis, and that patient had a respiratory alkalosis and a metabolic acidosis, the primary disturbance is the respiratory alkalosis, because that is in the same direction as the pH. If on the other hand, you had an acidosis with so the pH was less than 7.35, you had the same respiratory alkalosis and the metabolic acidosis, the primary problem would be a metabolic acidosis, because that is in the same direction as the pH. Okay. So in our example, you got an acidosis with a pH of 7.3. You've got a respiratory acidosis with a PCO2 of 60. And you've got a metabolic alkalosis with a bicarbonate of 30. But because your CO2 is in the same direction as the pH, the acidotic direction, you've got a primary metabolic acidosis. So you've got a primary respiratory acidosis, and the other disorder, which is the metabolic alkalosis, is what we call as the compensating disorder. Okay. Now I want you to understand this concept of compensation very, very clearly. Okay. So this compensation is to be understood very, very clearly. So what is compensation? In the presence of an acidosis or alkalosis due to the primary component, the other component moves in the opposite direction in an attempt to minimize the effect of the primary component on the pH. Okay. It does not mean that the other component, the non-primary component, normalizes the pH. It never normalizes the pH. So if you got, say, a respiratory acidosis, the metabolic component will become alkalotic, not to restore the pH to normal, but to minimize the impact of the respiratory component on the pH. So it will be near 7, it will approach 7.4, but will never become exactly 7.4. Okay. So if you got a primary problem, your pH will never be absolutely normal because of compensation. Okay. I hope that point is clear to everyone. So if you've got a primary respiratory acidosis, a high PCO2, then what is compensating is a metabolic alkalosis, which is high bicarbonate. If you've got a primary metabolic acidosis, which is a low bicarbonate, you have a compensatory respiratory alkalosis, where the patient washes out CO2. So that's why you see patients who got metabolic acidosis, they hyperventilate. They appear to be hyperventilating to wash out CO2 to minimize the impact on the pH. You have a low PCO2. On the other hand, if you've got a respiratory alkalosis, which is low CO2, you'll have compensatory metabolic acidosis. And if you've got a primary metabolic alkalosis, you'll have a compensatory respiratory acidosis. Okay. So Now, if that part is clear, okay, we'll just move on to the rules for compensation. Now, this compensation that we said, which the secondary component moves to neutralize, not to neutralize, to minimize the impact of the primary component of the pH, it follows certain rules. And we have to know these rules quite well. So if the primary, now in our patient, the primary component was respiratory, right? Now, when your primary component is respiratory, there is an additional complication that we need to look at. You need to ask, we know that the metabolic change is compensatory, but we need to ask, is the respiratory disturbance acute or chronic? Now remember that if someone injects an acid into me, I will immediately start hyperventilating. Okay. So if my primary problem is metabolic, the response of the respiratory system to minimize the impact of the acid in the blood on the pH is immediate. So I will immediately start hyperventilating. It doesn't take any time for compensation to develop. On the other hand, if I've got a primary respiratory problem, okay, so suppose my CO2 goes up, someone shoots morphine into me and my respiratory rate becomes 3 or 4, my CO2 will shoot up. But my compensation is done by the kidneys by retaining bicarbonate. And the kidneys cannot compensate, or that compensation mechanism of the kidneys is not that rapid. And it takes at least about 24 or maybe 48 hours for the kidneys to retain, for the retention of bicarbonate to reach that level, which will minimize the impact on the pH. So in other words, if I've got an acute respiratory problem, then the metabolic compensation will be less. And if I've got a chronic respiratory problem, then the kidneys have had sufficient time to retain bicarbonate, and then my compensation will be properly developed. Okay, so you have to distinguish whether the patient has an acute respiratory problem or a chronic respiratory problem, because the rules of compensation are different for compensation for acute respiratory acidosis and compensation for chronic respiratory acidosis. So bottom line is you need to ask, is the respiratory disturbance acute, right? And how do we know the respiratory disturbance is acute or not acute? One is you can see the history, right? So someone who has been given a shot of morphine has acute respiratory acidosis, but someone who's a smoker and has got COPD may have a chronic respiratory acidosis, right? But you can also, by looking at the blood gas itself, you can make an estimation of whether the respiratory change is acute or chronic. So if the respiratory, now in an acute respiratory problem, an acute respiratory disturbance, a 10 change in PCO2 will result in a 0.1 change in the pH, right? So pH changes by 0.1 for every 10 change in the PCO2. Okay. So in other words, if suppose my pH, my CO2 goes up from 40 to 80. So there is a 40 change in PCO2. If it is an acute problem, my pH will change by 0.1 for every 10, so it will change by 0.4. And because it's acidotic, my pH will become 7.0. Okay. Now I know this is a bit challenging for most of us, because one of the reasons we opted for medicine is we were mathematically challenged. But this is one time where you still need to quickly think these things. Not very different, but difficult, but we just need to think again. So I hope this is clear that if the pH changes by less, if for an acute change, if the pH should change by 0.1 for every 10 change in PCO2. And if it is an acute change in pH, then for every 10 change in CO2, the bicarbonate changes by 1. Okay. Please remember this rule. For an acute respiratory disturbance, for every 10 change in PCO2, there is a 1 change in bicarbonate. Now, if the respiratory disturbance is chronic, and how do you know that the respiratory disturbance is chronic? The change in pH is less than 0.1 for every 10 change in CO2. So for example, if the PCO2 is 80, right? So you would expect in an acute change, the PCO2, the pH to be 7.0. But if the pH is 7.2, it means that the change in pH is less than what you would expect for an acute respiratory acidosis, and therefore this is a chronic respiratory acidosis. Okay, so that means that that is because now the kidneys have had time to reabsorb more bicarbonate and retain more bicarbonate, and therefore if you've got a chronic respiratory acidosis, there is a change of 3 to 4 millimeters of 3 to 4 milligrams of bicarbonate for every 10 change in PCO2. So I hope this is gone through. Okay, so in an acute respiratory disturbance, one change in bicarbonate happens for every 10 change in PCO2. In a chronic respiratory disturbance, there is a change of 3 to 4 milligrams of bicarbonate for every 10 millimeters mercury change in PCO2. Okay, so let's see if we can see in our example, the pH is 7.3, PCO2 is 60. So the PCO2 has gone up by 20. Okay, so there is a 20 change in PCO2, and the expected pH in an acute problem would be 7.4 minus 0.2, that's 7.2. Okay, however, the pH is 7.3. So this means that is a chronic respiratory acidosis because the change is not as much as we expected. And the expected bicarbonate in a chronic change is 3 to 4 for every 10 change. So it will be 6 to 8. So 24 plus 6 or 24 plus 8. So 30 to 32 is your expected PCO2. And our PCO2 is exactly as predicted by this rule. So our PCO2 observed bicarbonate is 30. And we have predicted that the bicarbonate will be 30 to 32. So this is as predicted. Okay. For a primary metabolic event, the respiratory change is compensatory, and this is not so complicated because we know that irrespective of the duration of acidosis, the respiratory response is very rapid, and therefore you don't have to worry about acute or chronic respiratory acidosis. We just say that the respiratory component is compensatory, and the rule of the thumb is for every one change in bicarbonate, there is a one change in PCO2, right? That's the rule of the thumb. You just want to look at the gas and quickly look, then the one change in bicarbonate, one change in PCO2. But there is a more exact calculation which is called Winter's formula, and this I think all PGs should know. It's available on all their smartphones, so don't worry about it. But this is a sort of formula for a metabolic acidosis, the expected PCO2. So if you've got a bicarb, which is a bicarb level, which is acidotic, the respiratory component is going to be compensatory. So the expected PCO2 is 1.5 into bicarbonate plus 8 plus or minus 2. Okay, please remember this formula. And for a metabolic alkalosis, the expected PCO2 is 0.7 into bicarbonate plus 21 plus or minus 1.5. This, please remember this Winter's formula. This is the only sort of formula that you need to remember. The others are reasonably simple to understand. Okay, so okay, I hope this part is also okay. So let's take an example of a primary metabolic problem. So here the pH is 7.3, which is acidosis. PCO2 is 35, which is a respiratory alkalosis. The bicarbonate is 18, which is a metabolic acidosis. And that means the primary event is a metabolic acidosis because the metabolic component, bicarbonate, is on the acidotic side, as is the pH. So now we know that the respiratory component has to compensate. And now the bicarbonate has, come down by 6 from 24 to 18. So we expect, like I said, rule of the thumb, the CO2 should also come down by 6. It should be 34, which is pretty close to 35. Or if you want to be more exact, we'll put it in Winter's formula. The expected PCO2 is 1.5 into 18 plus 8 or plus or minus 8. That is, so it's plus 8 is 35 plus or minus 2. So it should be between 33 and 37, and it is 35. So this compensation is as expected. Okay. So the real question is, why are we breaking our heads, or like we say in Bombaya language, why are we doing this matha fodi to calculate or see what is the compensation and whether compensation as per rules or not? Because a simple reason is that if your compensation is as per your calculation, if your compensation is as per the rule, it is a single acid-base disorder. if the compensation is not equal to your rule or equal to your formula or your calculation, then there is a dual or a multiple acid-base disorder. So I hope this is very clear. So for example, in this patient with a primary metabolic acidosis, suppose the pH, the PCO2, instead of 35, had been 32. Okay. Now you would have thought that, or say 30, P should have been 30. You would have thought that, yeah, this is, if you just look at very cursorily, you would say, no, bicarbonate is 18, P should was 30. So there is compensation for metabolic acidosis. But if we'll put in the calculation that the CO2, right, should have been 33. The lowest should have been 33. It would have been 33 or 37, but it is 30. So that is less than what is predicted. And therefore, there's an additional cause for respiratory alkalosis. The respiratory alkalosis is more than what is predicted by your compensation calculation. And that may be because maybe the patient is very anxious, he's got a respiratory infection and he's very more anxious, and apart from hyperventilating, he's more anxious and therefore he's blowing out more CO2 than he should. So all those sort of things you need to keep in mind. Okay. So if your calculation is not as per the if your compensation is not as per your calculation, then you've got a dual or multiple acid-base disorder. Now, if you got a metabolic acidosis, okay, then you have to do one more thing, and that is calculate what we call as the anion gap. And that is it tells you, so if you've got a wide, so this is normal anion gap, and it is sodium minus chloride plus bicarbonate. You don't take the potassium over here. You just take sodium and chloride and bicarbonate. And normally the gap should be less than 12. So normal sodium is about 140, chloride is about 100, and bicarbonate is about 24. Okay, 110 over here. So most blood gas machines nowadays give a higher chloride level of about 105 to 110. So this should be normally less than 12. If the anion gap is more than 12, it suggests that there is an accumulation of anions which are not measured, like phosphate, sulfate, lactate. So all these anions are not measured, but if you measure the sodium, the gap, that there is a measurable accumulation of unmeasured anions. Okay, and these are the common cause of metabolic acidosis, and is given by the acronym called mud piles. For example, M stands for methanol, U stands for uremia, D stands for diabetic ketoacidosis, P stands for some poisons, I is for infection, L is lactate, E is ethylene glycol, S is salicylate. So these are all sort of things which can cause anions to be added to the blood, and you get a wide anion gap. That's a wide gap acidosis. If the anion gap is less than 12, we call it a non-gap acidosis, right? And the common causes are two. One is loss of bicarbonate. Say, for example, in diarrhea, you lose a lot of bicarbonate, there is no acid added to the blood, but instead there is loss of alkali, that is bicarbonate, and therefore you get a non-gap acidosis. Or the other very important one is hyperchloremic acidosis. If you give large volumes of normal saline to someone, then you add a lot of chloride, and then your anion gap becomes small, and then you get a non-gap acidosis, which is a hyperchloremic acidosis. Please remember, when you look at the anion gap, you must adjust it for the serum albumin. So for every albumin, for every 1 gram of albumin, which is below 4 grams, which is a normal albumin level, you have to add 2.5 to the anion gap. So in other words, if your anion gap, say, is coming as 10, as say 11, you will say this is a non-gap acidosis. But suppose that patient's albumin is 2, right? So that is 2 below 4. So you should be adding 5 to the anion gap. So that means your anion gap is actually 11 plus 5, 16. So what appeared to be a non-anion gap acidosis is actually a wide anion gap acidosis. So always remember and never forget to adjust the anion gap for the albumin level. Okay. Now, I think in your MD exam, if you've answered till here and you've got the anion gap and everything right, I think you've passed, and you probably even got very good marks if you've done it nicely without the examiner having to prompt you every now and then you've done very well. The next few slides are if you want to take the gold medal. Okay. The next step is, does the change in the anion gap explain the change in the bicarbonate? Okay. So now remember when we talked about compensation, we said that there are, where there's a, we can straight away look at a multiple disorder if the compensation is not as per the calculation. Now this is another way of finding out even more information. Okay. So ideally your gap minus 12. So let's say your anion gap is 20. Okay. That means there should be 8 additional anions which have been added, right? And your bicarbonate should also fall by 8. So if your anion gap is 8, that should be the fall in bicarbonate. In other words, the change in anion gap should be equal to the change in bicarbonate. Okay, and this is a mathematical way of saying the same thing. If on the other hand, if the change in bicarbonate is less than the change in anion gap, suppose the anion gap has changed by 8, but the bicarbonate chain has changed by only by 4, it means there is some additional bicarbonate which has come in from somewhere, which is making the change in bicarbonate less than the change in anion gap. And then there is an additional hidden metabolic alkalosis. Remember, this is a gold medal issue. So, but please try and understand the principle, if not the formula or anything. Okay. And similarly, if your anion gap has changed by 8, but your bicarbonate has gone down by 12, it means there is some additional acid floating around somewhere in the body, and therefore there's an additional metabolic acidosis, right? And this is usually, it has to be a non-anion gap acidosis, which is usually chloride. So we'll just see an example, okay? So this is a 21-year-old patient, diabetic, who's got an acidosis, ketoacidosis probably. Anion gap is 23, so that means, right? And his bicarbonate is 18. And now his anion gap is 23, means the anion gap has changed by 11. Normal anion gap is 12. So this has changed by 11. The bicarbonate is 18. It has only changed, gone from 14, from 24 to 18. So it is changed by 6. So anion gap has changed has gone up by 11, but the bicarbonate has gone down only by 6. That means there is an additional alkali floating around, right? Now, then we have to figure out why that additional alkali is there. So why is your bicarbonate less than what is predicted? Maybe someone has given sodium bicarbonate to this patient with diabetic ketoacidosis. So maybe that is why this patient's bicarbonate is less, and that is a source of your hidden metabolic alkalosis. Now, this is an alcoholic with a 2-week history of diarrhea. His anion gap is 17. That means the anion gap has gone up by 5. But the bicarbonate is 10. The bicarbonate has gone from 24 to 10. So the change in bicarbonate is 14, but the increase in anion gap is only 5, right? 17 minus 12, 5. Bicarbonate has come. That means there's an additional metabolic acidosis, which is a non-gap acidosis, right? And that is probably because this patient had diarrhea and he's had bicarbonate loss in the urine. So you got a non-gap acidosis over here, right? And the same sort of thing can be taken by this index called the delta ratio, which is the increase in anion gap divided by the decrease in bicarbonate. The same thing it's looking at. Ideally, your increase in anion gap should be the same as the decrease in bicarbonate. If it is 1, it's exactly the same. If the delta ratio is less than 1, there is an additional metabolic acidosis. And if delta ratio is more than 2, it suggests an additional metabolic alkalosis. Okay. We'll forget about the urine anion gap, and I'll just wind up by seeing these 7 steps over here. Please remember, first see whether there's acidosis or alkalosis. Then you determine whether primary disturbance, whether it's respiratory or metabolic, in the same direction as the pH. For a respiratory primary disturbance, determine whether it's acute or chronic. For a respiratory disorder, determine whether composition is okay. For an acute, 0.1 change in bicarb for every 10 change in CO2. For a chronic respiratory disorder, 3 to 4 change in bicarb for every 10 change in CO2. Assess the normal compensation. For the metabolic acidosis, determine whether an anion gap is present. Okay. Determine whether other metabolic disturbances coexist along with an anion gap acidosis. Okay. And I think this, if you do this, you will be able to do very well with all your patients. I don't think I have time to go into cases or into the acid-base status or the oxidation gas exchange status. I'll be happy to take questions on whatever I have talked on so far. So thank you very much for listening. I'm sure you will forget this by tomorrow morning, unless you go and look at 100 blood gases by the end of the week. Yes, but I hope you got a general sense of what I've tried to tell you, and try and read more about this and solve some more cases on your own before we go. Yeah, thank you very much for listening.
Thank you, sir. Thank you, sir, for your wonderful lecture. Hello, sir. Thank you, sir, for your wonderful lecture. Actually, it's a very tough topic. You have handled it very nicely. Definitely, it will be very beneficial for the postgraduate students and also practicing anesthesiologists. Very well done, sir. That's up to you. So, any questions in the chat box?
I think they've already forgotten what I've told them, so there won't be any questions. It's not.
No,
It's
no,
a
sir.
very
It's not
common
like that.
occurrence.
It's not like that. Actually, the way, sir, you teach this topic, it's make the ABG analysis very simple to understand. I heard this topic from you in 2009 in Chennai. And since that, my base for ABG analysis becomes so solid. I understand that ABG is very well since then.
Okay, good. Thank you.
I hope
Very
all
nicely
PG
done.
also understand this ABG analysis, and they start now solving that ABGs in ICU. And as you said, they have to read this topic repeatedly, then it is become them to understand it.
And please feel free to circulate that video which I'd sent you, or even a recording of this.
Yes, sir. Okay.
Very nice,
So
sir.
can we move on to then next session? If
Thank you. Thank you,
yeah.
Dr.
Thank you so much, sir.
Thank you.
Thank you for excellent lecture.
Thank you. Thank you, Divaji, sir. Thank you, Rupali, madam.
Thank you, sir. Now I request our chairperson, Dr. Pradnya Madero ma'am, to introduce our next speaker, Dr. Hemlata ma'am. Please share Hemlata ma'am CV.
Yeah, it's indeed a pleasure to introduce Dr. Hemlata. She's a neuroanesthesiologist, and she's a professor in the Department of Anesthesiology, King George Medical University, Lucknow. She has several publications to her credit, 11 book chapters. Her main interest is neuroanesthesia, and she has been awarded as being an outstanding clinician in anesthesiology in 2019, and she has several credentials to her credit. Additionally, she's also done a fellowship in regional anesthesia from Ganga Hospital in Coimbatore in 2018. Her talk for today is the role of viscoelastic testing in coagulopathy and newer anticoagulants. So over to Dr. Hemlata. Dr. Rupali, Dr. Hemlata.
Is it visible now?
Yeah, it is. Yeah.
Extremely
Yes, ma'am,
sorry
it
for
is
that.
visible.
Yeah. And am I audible?
So yes, ma'am. Yes, ma'am. So we will start with Dr. Hemlata madam's topic.
Yeah.
I request Dr. Pradnya madam to please introduce our speaker.
I have already introduced Dr. Hemlata. She's a pioneer in neuroanesthesiology, and I think she can move on to her topic.
Yes, ma'am. Yes, ma'am. Thank you.
Thank you so much, ma'am. And extremely sorry for the delay caused. Shall I proceed?
Yeah, do.
Yeah. Thank you so much. A very good evening to everyone. My topic for today is role of viscoelastic testing in coagulopathy and newer anticoagulants. Basically, in the viscoelastic testing, I'll be discussing very briefly about the hemostasis and coagulopathy, the basics, then the different viscoelastic tests that are available, the thromboelastography as compared to the conventional coagulation tests, where it stands, the techniques of thromboelastography, the interpretation of its tracing, its various applications in the clinical settings, its advantages, limitations, and then I'll summarize it.
Then the another topic is oral anticoagulant agents. I will briefly discuss about its mechanism, pharmacology, indications, the lessons learned from some of the trials. Very few trials I'll be taking, maybe I'll be skipping that. Then measuring the blood levels or monitoring how it is monitored. Then whether there is a reversal agent for it, how to transition between the NOACs and the other anticoagulants, and when to stop before surgery. So all this I'll be discussing in the next half an hour. Starting with the coagulopathy, it is basically a condition in which the blood's ability to coagulate is impaired. This can cause a tendency towards prolonged or excessive bleeding, which is known as bleeding diathesis, and it may occur spontaneously or following an injury or medical and dental procedure. When we talk about the normal hemostasis inside our body, that is basically a complex activating and inhibiting system. It is a set of well-regulated processes that maintains blood in a fluid state, clot-free state, normally in the vessels. It induces rapid and localized hemostatic plug at the site of vascular injury, whenever there is a vascular injury. Both hemostasis as well as thrombosis are regulated by three components. They are vascular wall, platelets, and coagulation proteins. The coagulation factors, the coagulation inhibitors, and the fibrinolysis. Now, we all know about these coagulation factors, won't go into the details. Certain factors are more important, like we know the prothrombin, the factor 2, the tissue factor.
Slides are not changing, madam.
Not changing.
Yeah.
Is it changing now?
No.
No,
No,
madam,
it's
while
only
sharing
first
the
slide,
option,
which is.
Just a minute.
Can you make it a slideshow?
Yeah, it's already in the slideshow mode, ma'am.
But it's not moving.
It's not changing.
Ma'am, it's not in, I think, the slideshow.
Oh, we are not able to see it as that, yeah.
You're not able to see. Just a
can you
minute.
press F5 or something?
Not able to understand. Just a minute. The slides
Stop
are
the
there.
share.
On the
Yes, slides, it's a steady. So slides are not moving.
not moving.
Yeah, so you need to
Only
stop
first slide
sharing.
where.
It's on the first slide.
Yeah.
Sorry.
Yeah.
So I'm clicking on it.
No, stop the sharing, ma'am. And again, while sharing, select the desktop, the full view. So then only it will work.
First, I have to stop sharing.
Stop sharing, ma'am. Okay. Now click on this sharing mode.
Okay.
Share button. So you can see a first option, share entire screen. Can you see? The first option is share entire screen. It will say. When you click on the share button.
Share entire screen is there.
Yeah. Click on the entire screen, ma'am. And share. Yeah.
So,
yes.
Is it moving now?
Yes, madam.
You just try to.
Just try once.
Moving the, yeah, it's moving now.
Yes.
Yes, ma'am. Yes.
Yes, madam, it's moving.
Okay. So I hope it's visible and it's moving now. Yeah. So now coming to, it's visible now?
Yes, ma'am, it's visible now.
Yeah. So coming to these traditional coagulation cascade, as we all have been reading since ages, that it consists of extrinsic pathway, intrinsic pathway, and a common pathway. And there are various coagulation factors that are involved in the different parts of it. However, nowadays, a cell-based model of coagulation has come up, according to which coagulation reactions are localized to cell surfaces, and coagulation can be divided into three separate phases. First one is the initiation phase, in which low amounts of active coagulant factors are generated, which roughly corresponds to the extrinsic pathway of the traditional cascade. Then comes the amplification phase, in which the level of active coagulation factor is boosted, and this roughly corresponds with the extrinsic pathway of the traditional cascade. And then comes propagation phase, in which the coagulation factors bind to highly procoagulant membranes of activated platelets and fibrin clots are formed. As you can see, initiation, amplification, and propagation, these are the various components of this cell-based model. And both the plasmatic as well as the cellular component of these are involved in the whole process of hemostasis, starting from the coagulation clot formation to the fibrinolysis or lysis of the clot. When we talk about the traditional coagulation assays, the prothrombin time, they basically gives us a basic idea about the extrinsic pathway, any impairment in the factors which are associated with the extrinsic pathway. The APTT tells us about the intrinsic pathway, and the thrombin time tells us about the common pathway. So besides the test of coagulation, we also have tests of fibrinolysis in the form of D-dimer and the FDPs. However, these routine coagulation tests do not represent the cell-based model of hemostasis, and they provide little information about the dynamics of clot formation and the quality of clot. That's why we need this viscoelastic. As you can see here, all these conventional tests, the PT, APTT, INR, the bleeding time, the platelet count, D-dimer, all tells us about only a single point in the whole process of coagulation. Like if we talk about PT, APTT, and INR, they tell us only about the initiation of clot. The R is a point in the TEG value at which plasma-based clotting assays end. They don't tell us anything beyond that. To have a rough idea about the strength of the clot that has been formed, the platelet count and bleeding time comes into picture, and then D-dimer and FDP has a role in telling us about the lysis of the clot, the resolution of the clot. However, when we talk about the viscoelastic point of care tests, they provide in vitro assessment of the global coagulation test in the whole blood sample from beginning of clot formation till fibrinolysis. So they provide a better picture of in vivo hemostasis due to interaction of all cellular and plasmatic components compared to the conventional coagulation assays. So the various tests that are available, viscoelastic tests, they are thromboelastography. Another one is rotational thromboelastometry, and third is sonoclot. Thromboelastography is the most commonly used. Even in our center, we have thromboelastography, and in most of the centers in our country, TEG is more commonly used. As though ROTEM is also coming up in the recent times, but we have been using TEG since a long time. It is a hemostasis analyzer which monitors the thrombodynamic properties of blood as it is induced to clot under a low shear environment resembling sluggish venous flow. It does whole blood analysis, starting from the initiation of clot to clot development, strengthening of the clot to clot lysis. As you can see in this picture, the whole spectrum of hemostasis, starting from thrombosis at one end and bleeding at the other end. So we can have an idea of this, where our patient is standing in this spectrum. Based on the rate of clot formation, the strength of the clot that is formed, and the stability of clot or the dissolution, we can have an idea whether our patient is prone to or at risk of bleeding, or the patient is at risk of thromboembolic complications, or is in the center of this spectrum. A brief history of TEG. It was started in 1948 in Germany by Hartert, and it was not used for many decades initially, but for more than last 2 decades, it is in common use, and it is proved to be very useful. This is on the left side, you can see this is the TEG machine, thromboelastography machine, in which 2 tests can be run simultaneously. Here we have a cylindrical cup in which the whole blood sample is inserted, and inside it a pin hangs from above, which is connected to a torsion wire. We need 360 microliters of whole blood to be put inside the cup, and it keeps on oscillating throughout this testing at a degree of 4 degrees and 45 minutes. And as the clot formation ensues, the fibrin platelet complex that is formed between the wall of the cup and the pin, it transmits the motion to the pin, and the movement of the pin increases, and that is transmitted converted into electrical signals and is displayed on the screen of the TEG machine in the form of a graph. This one is another machine, which is a modern one known as 6S, which is cartridge based. So we are saved from all the preparation process, the preparation of the sample, measuring the sample and putting it in the cup. So this is cartridge based. The requirement of sample is that we need a whole blood. If we are running a point of care testing, when our machine is inside the OT, then we can simply take a whole blood in a plain vial. And the test has to be run within 4 minutes of collection of sample. But if our machine is supposed, we are not able to run the test immediately because either our machine is not inside the OT, it's somewhere outside in the post-op area or in the ICU. So what we can do is we can take the sample, citrated sample in this citrate vial, and we can run the test between 30 minutes to 2 hours. It's preferable to run before 1 hour. Now coming to the native tag. So the native tag is basically without adding any activator, but it is not of much use to us because the results will not be obtained immediately, even though it is a point of care test, but it will take some time to obtain the result. So we need to activate the process of coagulation in it. For that, we have to add some activators. And normally, choline is added as an activator in the standard tag, which is being performed at most of the centers. And to further hasten up the process, for example, in trauma patients who are bleeding profusely, in cases of massive bleeding, massive transfusion patients, tissue factor can also be added in addition to choline to further enhance the process of coagulation. And we will get the results immediately with the addition of tissue factor. Then we have certain special curves. Suppose if our patient is on heparin and it has not been reversed appropriately, then we can go for a heparinase curve. Here the blue curve is heparinase curve. Or what we can do is, if we are not sure whether the residual heparin is there in the sample, so we can run 2 tests simultaneously, the normal one and the heparinase curve, and we can interpret accordingly. So this is a graphical representation of TEG. As you can see, there is a straight line. This is the baseline. And from this point, that is from the initiation to this point where the bifurcation of the graph starts, that is known as R time or the reaction time. At the time at which the first significant clot formation starts, that is, the graph has bifurcated to 2 millimeter amplitude. And from this point onwards to the point where the graph has attained an amplitude of 20 millimeter, that is known as K time or the K value. And that represents the achievement of certain clot firmness. After that comes the angle, the alpha angle, where the bifurcation is there. And that tells us about the kinetics of clot development. After that, we look after maximum amplitude of this particular graph, which tells us about the maximum strength of the clot. 30 minutes after this maximum amplitude, whatever the amplitude is, that tells us about the percentage lysis, and that is known as LY30. So these are the basic readings which will be useful to us and which is required for interpretation. Though there are many other values also, but we won't go in the details. So this is a normal tracing. Here you can see the R value. Well, the range for these R, K, alpha angle, and all the values, this vary depending on what type of test we are running. So this one is a choline test run on a normal sample. So here you can see this is a normal, the R value is normal, the K is normal, the alpha angle is normal within the range provided by the machine. Everything is normal. The maximum amplitude also falls in the normal range. And CI or coagulation index, which is calculated from all these parameters, that tells us about the overall coagulation status. If the value is less than -3, then our patient is hypocoagulable. If it is more than +3, then the patient is hypercoagulable. And LY30 value. It helps us in getting a fair idea about the fibrinolysis or lysis of the clot. The normal value is less than 8 or less than 7.3. These are other parameters which we don't need much. Now, talking about the time to obtain the results. If we are using a choline as activator, then the initial results will be obtained within 4 to 8 minutes. Then the platelet functions can be assessed within 10 to 20 minutes after starting running the test. Then complete analysis of the clot can be obtained within 45 to 60. And in case of rapid take, on addition of the tissue factor, the results can further be hastened, which is very important in trauma patients. So these are 3 kinds of graphs superimposed on each other. You can see that the rapid take, the results can be obtained immediately. The normal values, the range of values that is provided for the rapid take will be entirely different from that I have shown for the standard take. As you can see here, these values represent that for the native tail. So the values are much higher. Coming to the applications, clinical applications of TEG for the monitoring of this coagulopathy, the bleeding as well as the thrombotic risk in our patients. It is helpful in the perioperative and the postoperative period, especially in certain group of surgeries like liver transplantation, cardiovascular surgeries, orthopedic surgeries, gastrosurgery, urology, neurosurgery, obstetric and gynecological surgeries. It is also useful in monitoring our ICU patients, and accordingly we can give the required components, the blood components to the patients. Then in trauma patient, in massive transfusion scenarios, and to assess the heparin reversal, assessing the effect of drugs like heparin or warfarin, their effects on the coagulation system. Also useful in monitoring of the hemophilia patients, especially when they have been given some factors, the factor 8 or the factor 7A, etc. Monitoring efficacy of antiplatelets, biplatelet mapping. This is an added advantage of TEG. By adding a platelet mapping kit, you can have an idea of the effect of the antiplatelet agents if our patient is on dual antiplatelet therapy following some PCI or some other procedure. So it can be very helpful in the interventional radiology, neurology, or the cardiology. Besides the bleeding tendency, the added advantage of these viscoelastic tests are its ability to predict about the hypercoagulable states in the wide range of scenarios and conditions, as well as the hyperfibrinosis states. It tells us much more about DIC than the information that we can get from the routine tests like FDPs and fibrinogen. Coming to the tracings, interpretation of these tracings. Simply by looking at the shape of these tracings, we can have a fair idea whether our patient is normal or patient is having some kind of, whether it is hypercoagulable picture or the picture points towards primary fibrinolysis, or the patient is, if the patient is on antiplatelet therapy, then the picture will be different. In terms of, there can be prolongation of the R value, K value, if there is the patient is having on anticoagulants or the patient is off hemophilia patients. Then if the patient is on antiplatelet platelet therapy or the platelet function is impaired, then the maximum amplitude will be decreased and the shape will be look something like this. Then fibrinolysis, the clot lysis will begin immediately, even before attaining the maximum amplitude. So this gives us an idea about the type of picture that we have in our patients. So on the left side, you can see these green graphs show us about the hemorrhagic pictures based on different type of defects in our patients. Like if the R and K value are prolonged, the patient needs the clotting factor, so we can transfuse fresh frozen plasmas. If the maximum amplitude is decreased to a large extent, then we can give platelets, RDPs, as well as SDPs to our patient. Then if the fibrinogen level is low, then that the alpha angle will be decreased. Also, the maximum amplitude, the contribution is 80% from the platelet function and 20% is the contribution of fibrinogen. So that will also be decreased to some extent. And on the right side, you can see there can be, if our patient is having a thrombotic picture and is predisposed to some thromboembolism or DVT type, kind of thing, then we will get to know from the check graph. So this one is platelet hypercoagulability as the maximum amplitude is increased. This is enzymatic or the plasmatic component as the R and K value is shortened. And here both components are there. And then this is secondary fibrosis in which initially the patient is hypercoagulable. The CI value is more than 3, but later on the LY30 is also more than 8. This is a basic decision tree based on, this is a qualitative one and this one is a quantitative one, which we need to refer in order to know which component to transfuse to our patients. This is one example of a suggested treatment, how much, which component and how much to give based on the values that we obtain of the R, the MA value, the alpha and the CI. One more, like I said, platelet mapping is an extension of the TEG technology and it is very helpful when our patients are on ADP receptor inhibitor or on thromboxane A2 inhibitors like the aspirin and the clopidogrel. So some examples I will be showing quickly. This is a normal TEG tracing in which the normal coagulation tests were also normal. You will get a picture. The result will be like this. The report you will get if you feed the values and other details of your patient in the machine. Then another example of this was a patient posted for review mismatched renal transplant. The baseline laboratory parameters were normal, and this was the hemostatic picture before the surgery, which was normal. So, as you can see, on day 1, everything was deranged. The R value was prolonged, K value prolonged, alpha and MA angle were decreased, and there was overall hypocoagulable picture. So FFPs and RTPs were transfused based on these findings and also the presence of clinical bleed. Clinical correlation is always advised because most of the time we go for this test based on the clinical indications. So despite a normal lab parameters, we had given FFPs and platelet in this patient, and on day 2, the values had returned to normal. This is a picture of overt DIC. These two graphs represent primary and secondary fibrinolysis. The above is the primary one, and the lower one is secondary, in which there is a hypercoagulable picture followed by this fibrinolysis. Now, this was a case, patient was undergoing craniotomy for meningioma, excision of meningioma, and patient was bleeding profusely. Though it's the pre-op values of the coagulation test were normal. So we had got our tag done with it. Despite the normal initial values, we had gone for a tag in this patient, and we got this particular picture. The above one is hypocoagulable picture, and based on that, we had transfused the blood components, and we got this picture after the transfusion in the post-operative period. And the patient was well managed with all the transfusions and control of surgical as well as this bleeding. And now, coming to the benefits of the tag, it provides real-time dynamic measurements of coagulation and fibrinolysis. It avoids giving patient unnecessary transfusions. Appropriate use of tag can result in genuine cost savings in variety of patients. It can predict thrombotic complications as in MI, ischemic stroke, DVT, and pulmonary embolism. A surgical etiology of bleeding needs to be considered whenever the tag is normal. There are certain limitations. Tag results are affected by sample characteristics, use of activators, and sample handling procedures. It is not sensitive to mild coagulation factor deficiencies. Normal tag values proposed by manufacturer may not be appropriate for different populations, like for the Indian population, if the range is for the American. Cost factor is also an important consideration. To summarize, tag may overcome several limitations of routine coagulation tests in the perioperative setting. A surgical cause of bleeding should be considered whenever tag results are normal. Tag provides useful, so it helps us in ruling out unnecessary transfusion instead of going for a component transfusion and to search for the surgical cause of bleeding and to supplement the PRBCs. And tag provides useful information in a large variety of clinical scenarios, assessment of hypo as well as hypercoagulable states, and it helps in writing the pro and anticoagulant therapies. The newer advances in hemostasis may change the patient management in the near future, and tag may come up in a great way. Now, a brief outline of the newer oral anticoagulants. So, NOACs or the novel oral anticoagulants are newer orally administered non-vitamin K antagonists. That is, which have displaced the VKs or the vitamin K antagonists, that is the warfarin, for many indications. They are directly inactivate the thrombin factor 2 and factor 10. That's why they're also known as direct oral anticoagulants. Basically, we have got two groups. One is the factor 10 inhibitors, which consists of apixaben, rivaroxaben, eroxaben, and betrixaben. And we have direct thrombin inhibitors or factor 2 inhibitors, that is dabigatran. So the first drug was that was approved or authorized by the FDA was dabigatran in the year 2010. There are only few FDA-approved indications for these agents, though they have been considered for other uses also, like in ACS patient also many trials have been done, acute coronary syndrome, but the FDA-approved indications are only these one. Dabigatran used for stroke prevention in non-valvular atrial fibrillation, rivaroxaben for post-op VTE prophylaxis, stroke prevention in atrial fibrillation, and treatment of venous thromboembolism. Apixaban is used for stroke prevention in atrial fibrillation and venous thromboembolism prophylaxis after major orthopedic surgery. Pharmacology, as you can see, everything has been here, but I think I won't go into much detail. And mechanism I have already told, it is direct inhibition of the factor 2 and the factor 10. Now, coming to the individual drug, dabigatran, it is normally used for stroke prevention in atrial fibrillation in the dose of 110 to 150 milligram BT. And it crosses the placenta, so it should not be used in pregnant patients. And it degrades on exposure to air, so it must be kept in original packaging. Next one is rivaroxaban. It has got different doses for different indications, like 15 to 20 milligram OD for stroke prevention, 10 milligram OD for prophylaxis of VT, and 15 milligram BD for treatment of venous thromboembolism. And for secondary prevention of venous thromboembolism, it is given in a dose of 20 milligram OD. And it is avoided in severe liver disease patients. The dose of apixaban is 5 milligram BD for prevention of stroke in atrial fibrillation. There are certain dose modifications if the patient is elderly or if creatinine clearance is on the lower side. Now, a few studies that have come up in the recent years, it's more than 10 years, almost 14 years since they have authorized by the FDA for use. So there are many randomized control studies have been done like these. So what are the lessons that we have learned from all these studies? The main result of these studies was that newer agents are at least as effective as warfarin or the vitamin K antagonist and can be given without routine monitoring. However, there are unexpected findings also, like reduction in intracranial bleeding is there, but there can be extra bleeding risk higher in older patients. When we talk about the efficacy and safety of apixaban as compared to warfarin, the benefit of switching from warfarin to the new oral anticoagulants appears to be greatest only in those patients in which the INR control is very. Here, can these be used in patients with mechanical valves? Well, no. It is not used for in patients with mechanical valves, only in the non-valvular atrial fibrillation cases because of the extra risk that it has got. Now coming to the use of these NOACs for treatment of venous thromboembolism, there has been many studies which have been published, and they have found that the efficacy is comparable to warfarin. However, the safety profile is superior to that of warfarin. And we have the added advantage of no requirement of monitoring, no injections required, and no transitioning, single agent treatment. So, and shorter hospital stay. So this is advantageous as compared to the warfarin. For prophylaxis of venous thromboembolism, less thrombosis have been noted. However, more bleeding has been seen as compared to low molecular weight heparin. Now, do we have reversals of these novel oral anticoagulant agents? No specific antidote as of now. However, newer agents are in development. For example, activated charcoal, rivaroxaban, and apixaban effect may be reversed by giving prothrombin complex concentrate. And moreover, dabigatran is also dialyzed. So we can look forward to more to the reversal agents for these in near future. These remain favorable when we talk about patients with moderate renal insufficiency. So as compared to warfarin, these are more favorable efficacy profile and safety profile. Now, regarding monitoring of the patients who are on these NOACs, predictable anticoagulant effect enables administration of a fixed dose without need for any routine monitoring. No need to go for PT, APTT, INR or anything. For any medical complication, estimation of coagulation level might be of some help. However, not sufficient to assess the precise level of anticoagulant effect. Now, transitioning between the drugs is very important. If our patient is already on unfractionated heparin and we have to switch over to NOACs, then we need to start NOACs only when the unfractionated heparin infusion has stopped. So LMWH, if our patient is already on these low molecular weight heparins, then we need to start NOACs 2 hours before the next scheduled dose of this LMWH. And if the patient is on warfarin, we need to wait till the INR is less than 2. Then only we can start our patient on NOAC and without regular routine monitoring. Now, if we need to transition our patient who are on an oral anticoagulant to parenteral anticoagulant. So if the creatinine clearance is more than 30, then we have to start 12 hours after last dose of NOACs. And if the clearance is less than 30, then we need to give a gap or a delay of 24 hours before we can start the parenteral anticoagulants. And if we have to switch over to warfarin, then in patients with creatinine clearance more than 50, we can start warfarin 3 days before we stop NOACs. And between 31 to 50, we can start warfarin 2 days before stopping the NOACs. And between 15 to 30, the creatinine clearance, we can start warfarin 1 day before stopping the NOACs. So we should remember that NOACs can prolong PT and INR to some extent. Dabigatran can delay. If patient is on dabigatran, then we can further delay if we have to switch over to parenteral anticoagulants. And INR may be affected by dabigatran for 1 to 2 days even after stopping the drug. So when to stop the NOACs before surgery in the preoperative period? So NOACs need to be stopped at least 3 drug half-lives prior to the surgery. So in case of dabigatran, it is 42 to 51 hours. In case of rivaroxaban, it is 15 to 27 hours. In case of apixaban, it is 24 to 48 hours. And if the age of the patient is more than 75 years, we need to allow more time. And if there is impaired renal or liver function or hypertension, in those cases also, we have to wait little more. So who are the best candidates for NOACs? Patients who have unstable INR on warfarin, not due to poor compliance. Reasonably good renal and hepatic function. No mechanical valve. Patient is not pregnant. Patient should be less than 75 years old. No history of lower GI bleeding and should not be at high risk for acute coronary syndrome, especially if we want to start dabigatran. Conclusions. Administration of anticoagulants has been transformed by the use of newer oral anticoagulant agents. They have become the mainstay of treatment and prophylaxis of venous thromboembolism and stroke prevention in atrial fibrillation, the non-valvular. The area of additional indications is also growing faster. Routine monitoring of renal and hepatic function, signs, symptoms of bleeding, and patient's compliance should be considered in these patients, and the role of NOACs is critical in preventing thrombotic events. Thank you so much.
Thank you, Dr. Hemlata, for this very intense and in-depth presentation on viscoelastic testing and the newer anticoagulants. Now, many of us in the medical colleges, we really don't have TEG available, but I had this opportunity to use it for some of our liver transplants which we had, and it is indeed a boon in these situations.
Yes.
And similarly, regarding newer anticoagulants, many of the patients, especially who are for orthopedic surgery, they are on these newer and oral anticoagulants. So it is necessary that we know when to stop them and what are the issues related to these newer oral anticoagulants. So it was a wonderful talk. I really don't see any questions in the chat box, but it was really a good session for our PGs and even for many of us. Rupali, should we move on to the next?
Yes, ma'am. Thank you, ma'am, for a comprehensive talk. I'm sure it will benefit a lot, especially our PG students for exams. Now we move on to our final but very important talk on labor analgesia by Dr. Sunil Pandya sir. I request Dr. Pradnya madam to please introduce our speaker.
It's indeed an honor to introduce Dr. Sunil Pandya. He really doesn't need much of an introduction. He's a pioneer in obstetric anesthesia and high-risk obstetrics in critical care. He's the chief at the Department of Anesthesiology and Perioperative Medicine and Critical Care at the AIG Hospitals, Hyderabad, a consultant at the Fernandez Hospital, and director of the Prerna Anesthesia and Critical Care Services. Today, he will be presenting on his very favorite topic and something which we all really want to listen to, that is the labor analgesia. Over to you, sir.
Good evening, all. My slides are visible. Am I audible?
Yes, sir, yes.
At the outset, I would like to thank the organizers of IS MIRAJ-SANGLI for accommodating me and postponing my session. I was traveling and the flight was delayed. So thank you very much, the team, for accommodating me towards the end of the session. So without much ado, let me begin on my topic. Labor answer. Before I start my discussion, a disclaimer: all the equipment devices belong to our institute, and there are no industrial conflicts. And pictures have been obtained with the patient's consent. And importantly, what I'll be discussing is our protocol and our evidence and the current evidence as well, because we have a very stringent protocol of doing our own audit introspection and then subsequently going up the run. If you look at the history of obstetric analgesia, labor analgesia, it began 3 months after the demonstration of ether by WTG Morton. So October 16th was the date, and this was on January 19th, 1847. 3 months later, James Young Simpson administered ether to a lady with deformed pelvis. And he was a professor of midwifery in Edinburgh. And Simpson wrote at the end of the delivery that this lady would not have delivered had she not been given analgesia. And thus began the journey of labor analgesia. Of course, this was etherization, and subsequently there is significant history for next 40 years, but I don't want to go to the history. In a nutshell, parturients, they do require pain relief because of the physiological response of pain, and we know that the sympathetic nervous system that stimulates, and we know that this was another gentleman, John Snow, who administered analgesia to the queen while queen in birthing the 14th child and the 7th child, and the pain is intense and it affects heart disease complicating pregnancy, or who have respiratory ailments like scoliotic lungs or pulmonary fibrosis or bronchial asthma, or patients who have metabolic acidosis or fetal acidosis. Giving good pain relief during labor helps in improving the acid-base balance. And we know that the pH and the lactates are superior when the mother receives labor analgesia. The pain of labor is intense, and I don't want to go into the details, but we know this was the pain rating scale that was adopted by McGill. And if you look at the intensity of labor pain, even in the trained early parents, it was much more than any of those pains that a common man experience, a common woman experience, like fracture pain or cancer pain or phantom limb pain. The pain of labor was very, very intense when the rating was done. So they do require pain relief, especially parturients who have associated medical issues, when they have compromised uteroplasmic circulation, when they have prolonged labor for some reason, or when they are for VBAC, vaginal birth after cesarean section. In fact, that is one of the indication for labor analgesia, because we have our own data which suggests that the mother who has epidural for VBAC or TOLAC, it does not mask the pain of scar dehiscence. At the same time, it improves the incidence of the success of vaginal delivery. And especially certain special conditions like intrauterine fetal demise, where the mother already has lost the baby, so why give her painful labor? So the only word of caution is if the fetal demise is more than 2 weeks duration, you may have to check the fibrinogen level, because sometimes long duration IUFDs can be associated with hypofibrinogenemia. Breech nowadays are being delivered now vaginally, and it helps in controlled delivery of the aftercoming head, because This is one condition where a good effective pain relief in the second stage of labor, the parturient can push when you told when you tell her to push, rather than a parturient does not get any pain relief, and once the pain contraction starts, they just have urge to push. Just a precipitous delivery. So that is the beauty of epidural, where you can have the controlled pushing. Children are especially indicated mothers to take epidurals, especially they fall in this category, and those who are likely to undergo section, so that we can establish a successful analgesia, because we know that the incidence of cesarean section also is high in this obese parturients, and if we have a working epidural, it becomes easy for us to convert into cesarean section. I already told you about the cardiovascular diseases, other things which are important indications. Of liver analgesia. The patient eclampsia not a contraindication for epidural, provided the platelets are more than 70,000. And scoliotic back physiologist, so that you can site the epidural without axial imaging, so that you can minimize the number of attempts. So importantly, painless labor is a boon to parturient, and you can see a smiling face parturient ambulating with epidural. So what are the methods of pain relief? There are multiple methods. I won't be discussing much on non-pharmacological methods, but because it's a topic which encompasses all the methods, the non-pharmacological methods like support in labor by doulas or dayas, touch and massage, the transcutaneous nerve stimulation, water baths, intradermal style injections, hypnosis. There is no robust evidence to support that these work well, but yes, especially when the epidural services are not available, or when you don't have effective analgesia in terms of IV remifentanil, IV PCI, any of those things, then these techniques may be of some help, because the Cochrane data says that the amount of quantum of pain relief is about 5% to 5 to 10%, but psychological is better tolerated. TENS works by the gate control theory, not much of help, but as I said, if you don't have neuraxial services or IV PCA with remifentanil, then these things can become a modality to provide alternate analgesia. But again, on a scientific basis, there is no robust evidence that these are useful techniques. When it comes to parental narcotics, I'll come to it a little later, but inhalation analgesia in terms of Entonox or Nitronox, which is available in the US, again, not much of use in our country. We had the opportunity to have Entonox. We have Entonox in our hospital, and the cost per patient comes to almost about 1,500 rupees to 2,000 rupees. And almost about 50 to 60% of Entonox, they cross over and they ask for epidural. So overall, the cost goes up. But nevertheless, if you don't have, again, neuraxial services, Entonox again is a boon, because in grand multis indicated like coagulopathy, these things can be of help. The only concern with Entonox is the OT pollution or labor room, labor ward pollution. Even though they come with a control valve, the labor ward pollution can happen. Whether you can give 50% nitrous oxide, 50% oxygen through the anesthesia workstation, it is not feasible, because the maximum flow that the anesthesia workstation gives is about 15 to 20 liters. And if you look at the laboring parturient during labor, they hyperventilate, and the peak inspirative flow is somewhere around 30 to 40 liters, which this valve gives. So you cannot administer effectively Entonox or 50% oxygen nitrous through the anesthesia workstation. And importantly, giving Entonox or mixture of oxygen and air or oxygen and nitrous oxide through the workstation, atmospheric pollution is very, very high. So that is not recommended. When it comes to systemic analgesia, again, it is convenient, it is simple, and a lot of data, especially use of pethidine. Morphine was used in 1940 to 1950, the twilight anesthesia. Morphine, scopolamine was used, but we noted that the babies that morphine, but pethidine has was used almost for 50 long years and still is being used as an alternate modality for analgesia. But the problem is incomplete analgesia, neonatal respiratory depression, and maternal side effects like constipation or sometimes deletion. So if you ask me, the analgesic of choice as far as intravenous analgesia is concerned is remifentanil, of course, the number one, and fentanyl as alternative. But we don't recommend the usage of partial agonist and antagonist, because all said and done, respiratory depression is one of the complications. And if you have to reverse this, it cannot be reversed in a neonate. And ketamine usage should be condemned in labor because it can cause dissociative anesthesia, and you need to give benzodiazepine to counter the emergence phenomena. And it suppresses pharyngeal laryngeal reflexes and prone for aspiration. So remifentanil is the drug of choice, followed by fentanyl. IV remifentanil has been in vogue, and currently it is available in our country also. And the only catch here is a number of data. There are a number of studies have happened where the remifentanil usage is progressively increasing, and it is close to the efficacy of analgesia. It matches that of epidural, is what they say. We don't have much data in our hospital. Remifentanil in Hyderabad is still not launched. It's still not launched because pharma companies are not to other. But importantly, I case reports of analgesia, depression patients, they have for respiratory arrest, and there are so remifentanil administered under the supervision. One trial which was done recent past, and remi versus pethidine, and there was less conversion from epidurals, and there was not much of complication. But again, importantly, remifentanil has to be administered under the supervision of anesthesiologist only. Coming to inhalation analgesia, Entonox has its own side effect, but there have been short studies where the sevoflurane was used, Cevox was used, 4% Cevox or sevoflurane with air oxygen mixture was used with a special vaporizer which cuts off at 4%, and the analgesia was effective, better than Entonox. But the problem with Cevox is the mothers were in alternate phases of loss of consciousness and wakefulness, and over a period of time, it led to increased incidence of delirium. So Cevox also is not recommended. So coming to the main part of the discussion, the gold standard, the regional anesthesia is the gold standard because it's the only technique which effectively relieves both the somatic pain and the visceral pain by the combination of local anesthetic and the narcotic. And historically, the first intrathecal analgesia was given by Oscar Christ in 1900. Cocaine was given intrathecally for pain relief, worked very well. So coming to technique of our choice, I would say 98% of our parturients receive epidural as a technique of choice, and the most preferred space is L2, L3, or L3, L4. And we use loss of resistance to tactile and saline, and we have a special technology to minimize bloody taps for patients who are going to be on anticoagulants or patients who have low platelets. We have to minimize bloody taps because the incidence of intravascular inadvertent catheterization is almost about 5 to 7% in parturients. And the technique that we have innovated and we have invented, I would say, is the continuous saline flush technique, wherein we identify the epidural space with a tube needle and thread the catheter in the Huber point. And once the catheter reaches the Huber point, we attach a saline syringe and advance the catheter. The advantage is anything that comes in front of the catheter gets sidelined, and you can minimize the bloody taps. We did initially with open-ended catheters, the aero catheters. You can see the wire reinforced catheter. Subsequently, we did this study with lateral eyed catheters, the commonly used catheters, commercially used catheters, and we found out the incidence of bloody tap was very, very low. This has been published in the book also. The second technique of choice in our center is the combined spinal epidural analgesia. Again, we don't use it as a routine. As I said, 98% are standalone epidural. I would say less than 2% are under combined spinal epidural. Either the indications either very early labor or very advanced labor, or when you're anticipating difficult technique, or when you're doubtful about the epidural placement. So in partials or morbidly obese, or we anticipate that you didn't have a classic loss of resistance to saline, then you can use this technique. Otherwise, it's not a routine technique. We generally use sequential combined spinal epidural. Very rarely we use different spaces, different needles, because sometimes there is a possibility that you may shear the epidural catheter. So we don't advocate the 2 spaces and 2 needles technique. The advantage is the dural puncture epidural analgesia. We have done a study in our own hospital. We didn't find any added advantage, as has been reported by various journals. So we don't use this technique at the moment, because the advantage which they claim has been more of theoretical rather than practical. The single shot spinal analysis, again, if you ask me, probably less than 10 procedures. We do on an average about 20 epidurals for labor a day, and about 10 a year we do single shot spinals. The reason is we know that spinal acts for a limited period of time, say about 1.5 to 2 hours, and after that, if the labor gets prolonged, we end up doing one more procedure. So if at all we are giving spinal in a very uncooperative patient, or who are advanced stage of labor likely to deliver, like multigravida, or generally what we do is we give spinal followed by continuous lumbar epidural immediately at the same setting. We explain to the patient so that if the labor gets prolonged, or if the parturition gets converted for undergoes caesar section, then it's easy to convert. Otherwise, you end up giving one more spinal with the increased incidence of PDPI. A word of caution: if at all you're using spinal, always use you go for Whittaker needle or pencil point needle, not Quincke needle. The fourth technique, the analgesia, very rarely we do it, only for the fellows, because we run fellowship program only for teachers. We have found out that the virus quite high. So use this only when there's inadvertent wet tap with a indulge upon giving you give epidural, the resuscitation equipment to do ACLS is very, very important. I must tell you that last 28 years, we have not had any of the mishaps. Hello, any mishaps. But having said that, you need to have this equipment. You need to develop a habit of reading the CT tray, so that you know what the CT is like. All the things can be that you have. We have a significant obese parturients and analgesia can be discussed. Very important protocol where we explain about 2 important things. One is in incidence of failed epidural incident, all any of such things happens in Italy. 88% acceptance of labor analgesia. We have our data compared with international data, so that they know they can compare themselves, like what is the time things. It's easy for you to counsel things that we don't give go for incremental low dose mixture. The low dose mixture is. Am I audible? Hello.
Yes, sir. Yes, sir. You're
I
audible.
have connected my personal hotspot from the mobile. I hope that is better.
Yes.
So,
Yes, sir.
the preferred drugs that we use, so generally we follow low dose mixtures or ultra low dose mixtures given incrementally as a test dose. And the dosage, generally we have moved to ropivacaine for all the cases. Initially we were using bupivacaine with fentanyl, but now we have moved to ropivacaine. So generally what we do is once we set an epidural catheter, we activate the catheter using ropivacaine with fentanyl, using the volume of about minimum 12 to 20 ml given incrementally. And we repeat this dose every 90 to 120 minutes if we are giving bolus. Otherwise, we can put the patient on PCA pump. How about levobuprofen? Old paper 2000.
Sir, again voice is breaking.
Paper, and subsequently there is not much of change. Bupivacaine, all three are comparable, and they say that ropivacaine is relatively. Hello.
Hello. Hello, sir.
Am I audible?
Now you're audible, sir. In between, it is the network is fluctuating.
I'm so sorry. I'm so sorry.
No.
Yeah, I apologize. Inconvenience.
Now it is very audible, sir.
Yeah. So basically, we don't advocate usage of clonidine. Neither we use neostigmine, neither we use dexmedetomidine, because currently the literature on usage of dexmedetomidine neuraxially for labor anesthesia is very limited. But there are few studies that they say that the usage of dexmedetomidine in second-stage labor is of some help, but we don't use it because still it's not approved by FDA. How do you, once you give a epidural, initiate, activate the epidural, how do you maintain? And this is what we do. We started off with, we generally very fond of intermittent boluses every 90 to 120 minutes. But continuous epidural infusion, we don't recommend because the incidence of assisted vaginal delivery is very high. So I would say that PCA, patient-controlled epidural analgesia without basal infusion or programmed intermittent epidural analgesia boluses is the technique of choice currently in our hospital. So if you ask me, yes, the technique of choice is manual intermittent boluses given by the anesthesiologist, not by the nurses. MIB is manual intermittent boluses by the nurses, manual intermittent boluses by the anesthesiologist. So we generally, in our hospital, the nurses are quite experienced and they are comfortable in giving boluses because we have trained them. But we instruct our colleagues that they themselves go to the labor room and give the boluses intermittently. If not, they go for patient-controlled regimes, which are important. PCA, there are multiple studies. They are quite helpful, and we follow a philosophy of selective sensory blockade and mobility of labor. Even if the mother doesn't want to ambulate, we give ambulatory analgesia for all cases universally in our hospital. And you can, many doctors, they prefer taking epidurals. The protocol for ambulation again is very well defined so that there is no fall or any of those mishaps during ambulation is very important. And these are the CAT Solis pump that we are currently using, the CAT pumps, and we are also using the Arcomet pump. Again, when I take these names, nil conflict of interest for this company, but these pumps are very good because, and you can see the extension line is red in color so that there is no ambiguity, there is no mixture, there is no confusion. You can program it in such a way that the programmed intermittent epidural boluses goes at fixed interval, and if the patient has any pain, they can also take bolus intermittent, and you can limit the number of dosage or volume of drug that has to go every hour so that the patient does not inject accidentally. So currently, if you ask me, manual intermittent boluses and PIEB with PCEA is the best regime currently available. And these are the regime that we follow in our hospital for PIEB. Bolus of 10 ml, PIB interval is 45 minutes, and PCA bolus is 10 minutes boluses with 30 minutes lockout interval, maximum 20 ml per hour. But again, at the level of epidural is also very important at what level you're starting, because there are indications sometimes if the patient has pathological back where they have had laminectomies or scar in the lower lumbar region, we place lower thoracic epidural, in which case the bolus, the volume has to go down. There are certain newer advances that have happened in the field of labor analgesia and the ultrasonic guided neuraxial blocks, the SUI simulation needles, optical neuroepidural needles, and all those things have come in. These are the device that we introduced again for the first time in India in 2012, the acoustic puncture resist device. They help in localizing the epidural space. Basically, all these devices help localizing the epidural space with the acoustic signal, and there are different needles which like drum epidural needle with drum, or the episure needle with a spring-loaded needle, or you have epimatic needle. Again, it's an elastic band that is there from the Vicon. Again, as I said, nothing needle conflict of interest. And this is the SUI needle, and this is the optical needle. So basically, different needles are available to help the anesthesiologist localizing the epidural space. We are comfortable using TUI needle. We are comfortable using the conventional TUI needle. And yes, neuraxial ultrasound is something which is in vogue, very much in vogue, and everybody has to embrace this skill, because we know we can select the appropriate space, the right interspace, the trajectory, and especially in students who are obese, landmarks are poor, and we developed our own classification of spine. This has been validated. Of course, not published, but it's been validated in our own place. And whenever the airway grade is more than Malampati grade 3 and grade, and it helps us in way to minimize maternal morbidity. When to initiate epidurals, there are lots of controversies as to labor analgesia, early versus late epidural. We don't wait for arbitrary cervical dilatation of 5 centimeters above. So whenever the mother requests epidural, either she is 1 centimeter or 2 centimeters dilated, we initiate epidural, because we know that early epidural institution does not result in increased cesarean section rate, as it was earlier approved. We know that epidural does not lead to increased cesarean section rate. We don't withhold the pain relief in second stage of labor. The whole purpose of giving epidural is not served. The long-term backache with epidural is non-existent, does not exist. Neonatal outcomes are not affected with epidurals. Maternal satisfaction definitely is better. Fentanyl that we give for epidural analgesia does not affect or impair breastfeeding. Multiple studies on this. You need to have, of course, active maternal bonding program, so that you have those baby walk the moment the baby or enhanced lactation. And there are a lot of studies of late coming up where they say that good analgesia reduces postpartum psychosis and maternal respiratory depression. So definitely epidural is very beneficial in reducing maternal depression, psychological depression or psychic depression, and psychosis also. There have been instances where epidural was blamed in early 2000, that the babies born under epidural analgesia, the autism rate was high in the babies. And subsequent, there have been several studies. There is a robust data now that autism, and there is no relation between autism and labor epidural analgesia. So I can go into the questions if they want to know more. But yes, as I said, maternal request is enough to take epidural. And over the years, we have seen that it does not increase the rate of cesarean section. The epidural rate the epidural take rate is increasing, but the cesarean section rate is decreasing. This is the data from our own hospital, non-epidural versus epidural. The C-section rate, in fact, is more under non-epidural group than epidural group. Again, AVDs, the incidence of assisted vaginal delivery is 9 to 11%. Yes, mild increase in assisted vaginal delivery is there with epidural. Withholding the stage doesn't happen. People study is nothing but pushing early versus pushing late in labor. This study was done by Chestnut et al. In 2008, and they said that once the mother is fully dilated, do not encourage pushing. The pushing has to be encouraged only when the descent of fetal head has up to +2 or +1 station. Many a times it happens that the mother is fully dilated, but the presenting station will be at -2 or -1. And if you encourage this pushing, then they're going for obstetric labor. So late pushing is better. And this is what the data from our hospital is. So epidural improves the mental satisfaction. If you see, the incidence of unsatisfactory is almost less than 2% overall, but majority of them are excellent. So feedback has been very good. This was a paper on epidural and postpartum psychosis. Epidural reduces the incidence of postpartum psychosis, no effect on breastfeeding. Autism, again, there is no association with autism in epidural. The risk management strategies have to be in place when you're instituting epidural. This is very, very important because when you're giving epidural, be prepared for anything. The bloody tap, we use CSF technique. Last is very rare, but be ready with lipid rescue. A wet tap, we thread the catheter intrathecally and manage as intrathecal catheter. PDPH, we have one protocol, minimize the PDPH. And coagulopathy has been discussed extensively by Dr. Himlata, and pneumonic injuries have to be prevented. I think paucity of time, I can take questions. I can stop my presentation. There is nothing else. Yeah, this is the last slide. You need to introspect your own data so that you know where you stand. So basically, to conclude, epidural anesthesia is the most effective form of pain relief. PCEA regimes are very important, very good with PIEB combination. IV-PC with remifentanil is excellent. Ultrasound training is going to be mandatory for all the anesthesiologists. But when we discuss so much about ultrasound and regional anesthesia, not to forget or undermine the airway skills in pregnancy, because difficult airway is a true thing in pregnancy and you need to be well versed with difficult airway policy. So our policy is to give a pain-free mother without side effects is one of the most rewarding moments in the moments of medicine. Thank you very much.
Thank you so much, sir, for this wonderful and elaborate in-depth presentation. We have one question in the chat box.
The problem with the net. This is just an invite to all of you for our update on perioperative medicine, which is there next year, 22nd and 23rd March. We have good international workshops with reputed faculty. So invitation to all of you to join us and meet at Ahmedabad. Thank you very much.
So there's one question in the chat box regarding the dose of spinal local anesthetic and opioid, I think, in continuous spinal epidural and continuous spinal anesthesia, combined spinal epidural and continuous spinal anesthesia.
So excellent question. I didn't go into the. I think that's when the internet connection failed, and I couldn't speak on this. Say suppose if you have, as I said, when the incidence or the indication for continuous spinal anesthesia is when you have an inadvertent wet tap in our hospital. So when you have a wet tap in our hospital, what we do is through the TUI needle, we give 20 mg of fentanyl if the VAS score is less than 7 on 10. If the VAS score is very high, like 10 on 10, then we give 20 mg of fentanyl with 2 to 3 milligrams of preservative-free ropivacaine. So total volume is about 2 ml. And once you inject this, do not disconnect the syringe from the TUI because the fixation time of local anesthetic is almost about 5 to 18 minutes. So allow the drug to fix. We know that fentanyl fixes rapidly because the lipophilicity of fentanyl is almost about 750 to 800. So 2 to 3 minutes, the drug gets fixed. Then you disconnect the injecting needle, thread the catheter intrathecally for 3 centimeters only. Once the catheter is threaded intrathecally and mother is comfortable, we start the continuous infusion regime. And the regime that we follow is we take 20 milligrams of ropivacaine and add 100 mg of fentanyl, that is 20 ml at 10 ml of 0.2%, that is 20 milligrams, and 2 ml of fentanyl, and remaining saline in a 50 ml syringe, and give at 3 to 4 ml per hour. So each ml of this contains 0.4 milligrams of ropivacaine and 2 mg of fentanyl. So you run at about 3 to 4 ml per hour. You can titrate it. You can downgrade it. You can upgrade it. And mother is generally, I would say 95% of women are comfortable with this. If this lady lands up for cesarean section, disconnect the infusion and give the regular dosage for cesarean section incrementally because it's an intrathecal catheter. Just give with a 1 ml tuberculin syringe. Very, very important. 1 ml tuberculin syringe. Take 5% of, 0.5% hyperbaric bupivacaine and give 0.2 ml, 0.3 ml over a period of time and titrate it till you get an adequate block. And post-operatively, again, you can give the same infusion ropivacaine with fentanyl for post-operative analgesia and remove the catheter at the end of 24 hours so that you can minimize the risk of post-dural puncture headache.
Sir, in your practice, you were earlier using bupivacaine in low concentration, and then you switched over to ropivacaine.
Yeah.
Did you really find any difference between
No
the
difference at all. No difference at all. We switched over because people worldwide started using ropivacaine, and why stick to bupivacaine, and we switched over. But no added advantage. No added advantage.
Oh. I think there are no more questions.
Yeah.
Any more questions in the audience, Dr. Rupali?
No, ma'am.
Can't see anything in
This
the
is
chat
Dr.
box.
Ankita here. Yes, ma'am, there are no questions. With your permission, can we end the session?
Thank you. Thank you so much for the
you, sir.
opportunity, and sorry that there was some internet problem was there. Yeah. Thank you.
So thank you, sir, for a very practical talk. Your technique and experience will definitely be helpful for everyone. Special thanks to Dr. Prabhu, sir, and Dr. Pradna, ma'am, for chairing our sessions.
Thank you very much, Ankita. A pleasure. I have been associated with MIRAJ-SANGLI for 3 years, and it's a pleasure being with you all. Yeah.
Thank you, ma'am. Thank you so much. With this, we end the first day of our PG Assembly session. I would like to present my vote of thanks. First of all, I would like to thank to all our wonderful and respected speakers for their time and insights. I'm sure it will help us a lot in our practice as well. I would also take this opportunity to thank ISA National Office Bearers, Dr. Devatia sir, Dr. Bajwa sir, for giving us opportunity to arrange this assembly. I would like to extend special thanks to ISA MIRAJ-SANGLI Branch President Dr. Vasudha Zadav Madam and Secretary Dr. Rupali Gorgile Madam, who are also organizing chairman and secretary. Kudos to your efforts and hard works and arranging online sessions so that we could all hear to stalwarts in our field sitting at the comfort of our homes. A special thanks to Mr. Aditya Kulkarni from Thought Picker Company for a very smooth functioning of this online session. I hope all our delegates have enjoyed this and will join us sharp 7:30 a.m. tomorrow at the workshop venue. Thank you, everyone. Good night.
Thank you, everyone. Good night.
Good night.
Very
night.
well, excellent lectures and excellent sessions. Thank you, everyone.
Thank you. Thank you, madam.
Thank you, ma'am.
Thank you.
Thank you, all respected speakers and chairperson. Thank you.
Thank you, Pandya sir. In your hectic busy schedule, you arrange your lecture. Thank you so much. So we leave the meeting.
Thank you.
Yes. Thank you. Good night.
Good.